Everyone. Good morning. If I can ask everyone to please take your seats, we're going to get started in a few minutes. Good morning. If I can ask everyone to please take their seats, we're going to get started in a few minutes.
Good morning. Good morning, everyone. Welcome. I'm really delighted to welcome everybody to the Harvard Global Health Institute's inaugural Global Health Symposium. I'm Louise Ivers. I'm the faculty director of the Harvard Global Health Institute. And I'd like to just start with a few logistics notes. Inside your welcome packet, you'll find our agenda for today, as well as a QR code. We won't be doing extensive biographical introductions, but you can find out more about speakers and about the sessions. If you just click on the photograph of speaker, you'll find out more about them during the day. We're going to have refreshments for those who are here with us in Cambridge throughout the day in the East Dining Room just behind me. So we'll ask you to stay in your seats during the session, but feel free to move in and out in between sessions and grab some refreshments. There's restrooms behind you out through the hallway on the other side of the lobby. Many of our sessions today will have time for questions and answers, and we're really delighted to hear from you, to hear your questions and your comments. So for those of you who are in the room, we'll be just asking you to raise your hand during the Q&A. We do have a very large online audience. Over 1,200 people are joining us remotely, and we're really delighted for all of you to be part of that. So please, for those who are in the online audience, go ahead and use the Q&A feature on Zoom. We have a lot of our team on standby over in the corner, thanks in advance, to be looking at the questions, looking at the comments to bring them into the sessions. We do have one update to our agenda. Unfortunately, Dr. Sumya Swaminathan let us know earlier this morning that due to an urgency, she's very regrettably unable to speak today. So we'll actually just be extending the lunchtime session instead of her keynote. And so we are regretful about that change. And very lastly, this event is being recorded, and in a few days, we'll have the recordings available online if you happen to miss any session or you want to go back and take more notes on what you heard. So with that, I'm going to move to introduce Dr. Alan Garber. Dr. Garber is provost of Harvard University, and he's Harvard's chief academic officer. He's going to open the event for us. Provost Garber is also the Malincott Professor of Healthcare Policy at Harvard Medical School, a professor of economics in the Harvard Faculty of Arts and Sciences, professor of public policy in the Harvard Kennedy School of Government, and professor in the Department of Health Policy and Management in the Harvard T.H. Chan School of Public Health. As an economist and a physician, he studies methods for improving healthcare productivity and healthcare financing. And I'm very, very grateful that he's joining us, and I welcome you, Professor Garber. We can see you, and I'd like you to take it away.
Thank you, Louise. Can you hear me okay?
Yes, we can hear you great. Thanks.
Wonderful. Thanks so much. First of all, let me add my welcome both to the people who are present at the faculty club. I had hoped to join you, but couldn't today. But I'm also delighted that, as Louise said, there are more than 1,200 people participating online. So I imagine that for those who are online, it's many different times a day around the globe, wherever you're found. And I particularly want to thank the people who are participating at inconvenient hours for you, wherever you are. It's a real honor for me to mark this occasion as the first Global Health Symposium put together by the Harvard Global Health Institute. Let me just say, by way of background, that the Global Health Institute at Harvard was created for a fairly specific reason. There, as many of you know, there is a lot of activity and has been a lot of activity in global health throughout the university and its affiliated hospitals over the years. And I think that Harvard is a microcosm of what we face around the world. That is, how do we harness the talents of the many individuals who have a passion for global health and bring them together most effectively? How do we foster partnerships that will magnify our impact? And within Harvard, I think you would all be quite aware that we have a lot of global health activity in the hospitals, in the T.H. Chan School of Public Health, and in the medical school. But not everybody appreciates that the interest is far more widespread, including places like the Paulson School of Engineering and Applied Sciences, the Graduate School of Design, and the Kennedy School. Almost in every corner of the university, there is a passion to address the open challenges in global health. The Harvard Global Health Institute has had the great advantage of having some excellent leaders. From the beginning, it was Sue Goldie from the School of Public Health, followed by Ashish Jha from the School of Public Health, Alan Brandt with appointments in the med school and the Faculty of Arts and Sciences, served as more than an interim faculty director, and helped to put the Global Health Institute on a very promising new path. And the culmination is the appointment of Louise Ivers, who has connections throughout the university and through the world of global health. I emphasize the connections because I think this is a huge part of how you achieve success in this area. Louise, for those of you who know her, will agree, she seems to keep more balls in the air than is humanly possible and does it with incredible grace. And she brings a passion for global health and dedication to research and education. That's going to shape our activities for many years to come. Turning to the conference, its theme is Global Health Equity through Community Engagement. This reflects the ethos of the Global Health Institute, and it challenges us to think how we can partner most effectively in addressing some of the world's most important problems. An important task is to bring diverse human talent to bear on these importance. Within the academic realm, we usually speak about bringing together multiple disciplines and types of expertise, everything from epidemiology, immunology, entomology, economics, anthropology, and clinical specialties like infectious diseases, primary healthcare, obstetrics, surgery, ophthalmology. We also need to bring together people around the world who have very diverse perspectives and experiences. The resourcefulness, dedication, and expertise of researchers, field workers, and clinicians in the parts of the world that bear the greatest burden of the many global health maladies, like infectious diseases, malnutrition, child disease, inspires us and reinforces the importance of reaching wide to develop partnerships that will enable us to take on the most important challenges. The range of speakers and other participants here today, whether in person or virtually, illustrates the spirit of interdisciplinarity and international collaboration we hope to foster. Now, again, we are an educational institution. Teaching and learning are at the heart of all we do. We're not only working with external partners to try to address these important global health issues, but also educating students on our own campus and elsewhere, starting with our undergraduates. Global health and health policy is what's known at Harvard as a secondary field concentration. It's sort of like a second major for our students. It's achieved remarkable success within our college. It's one of the most popular secondary concentrations, usually the first or second most popular, and it attracts students from all backgrounds. The success of the program just demonstrates the tremendous hunger that our students have to get involved in global health. I can't help but think of how many more students pursue careers in global health because they were exposed to this program and others that we have that are offered through the Harvard Global Health Institute. We're committed to giving our students the tools and resources they need to become the next generation of global health researchers and practitioners. And we hope we can contribute to the training of students elsewhere in the world. We recognize the importance of combining service and research in teaching, and we hope to impart this in our students. In keeping with the symposium's theme, our speakers will be touching today on some of the world's most pressing global health challenges. They include building equitable partnerships to address HIV inequalities, the value of planetary health in addressing the needs of the most vulnerable populations, defining a community-based response to emerging infectious disease outbreaks. As you can see, much of the symposium is about unfinished business, as it should be. When we think about the enormity of the problems we need to address, it is easy to appreciate that we need a wide range of skills. I like to think about our late, much beloved colleague, Paul Farmer, and the lessons that he taught us. We all remember his combination of dedication, brilliance as a researcher, commitment as a clinician, resourcefulness, and creativity. I think we should all remember as well how he made us laugh. He never let up in his determination to help the world's most vulnerable. And despite disasters, both natural and man-made, and the pervasiveness of the disease, trauma, and death that he encountered in his work, he never lost his sense of optimism. We can do this, and we can do this together. We should all remember that despite the remaining challenges, there has been great progress in global health in recent decades. The much greater control of HIV disease, declines in maternal mortality, and improvements in child health have demonstrated that success is possible. AIDS-related deaths around the world have declined by 68% since the peak in 2004 and by 52% since 2010. And between 2000 and 2020, the maternal mortality ratio dropped by about 34% worldwide. We have much more to accomplish, and we must not desist in our efforts. But remember that even incremental improvements can represent thousands of lives saved. Let us harness our talents and dedication to continue on the path toward better health throughout the world, better serving our least advantaged communities. With that, I want to thank you again for being here with us today. And thank you to our partners, our speakers, all of you in the audience, and to Louise and her team for putting together such a compelling program. I hope that you will find this inaugural Global Health Symposium to be both enjoyable and illuminating.
Thank you so much for those very kind and welcoming remarks and a charge for the day. At this time, I have the pleasure of introducing our keynote speaker, Dr. Ahmed Agwal Ouma, the Acting Director of Africa CDC. In his role as director, he coordinates with member states of the African Union to address disease and public health. With over 25 years of experience in public health, Dr. Agwal is a longtime advocate for health systems reform, working with numerous health organizations to oversee local and country-level health policy changes by prioritizing the needs, ideas, and epistemologies of the African continent. We have been witness to his tremendous leadership in the continent's response to COVID-19. I'm absolutely honored to welcome him here with us. Dr. Ogwell, we're very delighted to have you. Please take the stage.
Thank you very much, Louise, and good morning, at least here. But for those online, it will be good afternoon, it could be good night, it could be good evening. And I must say that an inaugural event that attracts in excess of 1,200 participants is one whose time has come. Probably we are a little late if we have so many people interested in joining. And this is testimony to the fact that the world is becoming, I don't want to say smaller because it has not reduced in size, but certainly we are becoming more connected and our issues are becoming very, very similar. So it's an honor to be here, and my sincere gratitude to the Harvard Global Health Institute for inviting us at Africa CDC to participate in this inaugural Global Health Symposium. And we are also very pleased that this inaugural symposium is seeking to explore global health equity issues through community engagement. In fact, for us at Africa CDC, equity and community engagement are not just words. They are often the very difference between health security on the continent and catastrophe. When you don't engage with the community, you don't get to know when an outbreak has begun, and therefore your response takes weeks, and many, many lives are lost, and many more are disrupted. When you don't have equity, it means that the most vulnerable are the ones that receive any kind of support last, if at all they receive it. So when we hear equity and when we hear community engagement, for us, it is sometimes the difference between health and catastrophe. Today, the world is grappling with unprecedented challenges, not just in health security, but in security in general. It has become a much more dangerous place than it was many decades back. Unfortunately for health security, these challenges often translate into economic difficulties. It translates into disruptions of the social fabric. Indeed, health security has become a critical issue that affects all of us differently, but it affects all of us. For us, it is not just about preventing pandemics. It is not just about avoiding bioterrorism, but it is also about ensuring that everyone has access to quality healthcare as we accelerate progress towards a world that is safer from disease threats and health emergencies. Our goal at Africa CDC, the Africa Union, is health for all. And we are very pleased to see that this year's theme for World Health Day indeed was health for all. Over the past few years, we globally have seen how quickly a disease can be able to spread across borders. We have seen how devastating the consequences can be. And in fact, when we look back at the challenges we had with the Ebola virus disease outbreak in West Africa, and we mirror that with the challenges that we've seen with the COVID-19 pandemic, we see how exposed the world is. These large outbreaks have exposed existing disparities within and between countries, and they have been painfully reminding us that the multilateral system in the world has significant limitations when we are all faced with a shared health threat. This is not to say that the multilateral system failed, but it is to say that it was never designed to handle the kind of challenges that the world is facing today. That is why reforming the multilateral system is not only urgent, it will help us to avoid future painful experiences. We have seen firsthand, particularly in Africa, but also including the global north, we have seen how important it is to have robust health systems that respond quickly and effectively to any disease outbreak. Allow me, ladies and gentlemen, to remind us that today in Africa, it's the middle of April, and yet we have already experienced 44 outbreaks. 44 outbreaks. 19 of them were serious. In fact, apart from 19 being serious, as we speak today, as Africa CDC, we are actively responding to 5 of them. And this includes the simultaneous Marburg virus disease outbreaks in Tanzania and Equatorial Guinea, as well as the devastating cholera outbreaks across the continent, which have been made much, much worse due to the effects of Cyclone Freddy, particularly in the southern part of Africa. And we need to keep in our prayers Madagascar, Malawi, Mozambique, and parts of Zambia. The situation is not pretty, and the health situation is even more dire. Disease threats and their devastating consequences are not just real in Africa, they are becoming rather regular. And the effects of these disease outbreaks continue to weaken the health systems, and they also continue to disrupt our economic ways of life. The COVID-19 pandemic and these other multiple disease outbreaks have reminded us of the urgent need for a collaborative approach towards global health security. That word global is often forgotten when we are faced with threats, as we have seen during many of these outbreaks. These experiences that we faced have once again taught us that different countries must work together to build robust, resilient public health systems that can prevent, can detect, and respond to health emergencies in a timely manner. These experiences have also taught us that we can avoid or significantly delay the next pandemic if, and only if, we put the lessons that we have learned into tangible, urgent action. Unfortunately, where I sit at Africa CDC, we are not learning those lessons optimally. In fact, I am not so sure that we are preparing to avoid or delay the next pandemic. We seem to have forgotten about COVID, and we have quickly moved on. In fact, it is quite refreshing to see colleagues wearing their masks. We have forgotten that masks exist, and we have also forgotten that there were once things called sanitizers. But let me tell you a story. The story of an idea that evolved into a vision that then gave birth to the Africa Centers for Disease Control and Prevention, the Africa CDC. The story of a young institution thrust into the central theater of health emergencies and disease threats in Africa. The story of an African institution that is meeting its mandate despite the skewed landscape of public health globally. This is the story of commitment, a story of resilience, of action, a story of fidelity to safeguarding Africa's health. Let me tell you the story of a young African institution mandated by our heads of states and government to coordinate, to convene, and to build the capacities of African countries in public health and more urgently in health security. We've been asked to build the capacities of our countries to prevent, to detect early, to rapidly respond, and to build resilience before the next serious public health event. Many do not know just how young this institution is. Today, we are 6 years old, having been officially launched on the 31st of January, 2017. In these few years that we've been existing, we have documented hundreds of outbreaks on the continent. We have actively responded to dozens of them. And as we do that, we have learned lessons. These are the lessons that I would like to share with you today. Apart from learning those lessons, we have also taken the bold decision that we as Africa CDC and the Africa Union are going to put these lessons into alternative action. We want to see things change in the health security space in Africa and beyond, and we want to share our experiences so that the rest of the world can do better as we feel safer. It can no longer be business as usual. We are committed to make it business unusual because the situation on the continent demands and requires that the business as usual is no longer our way of working. Ladies and gentlemen, one major lesson we have learned is that global health security, in fact, that whole space is skewed against Africa. It is skewed against other regions who have resource constraints. If an outbreak, if you clap, the politician in me will talk for another 1 hour or so. If an outbreak is small, one lesson that we've learned, if an outbreak is small, it does not attract the required attention, neither does it attract the required solutions or resources. And a good example is Mpox. You know, last year, the Mpox outbreak on the continent started in, well, the conversation was last year, but for us, it started in 2020 in March, just after COVID. We spoke to everyone we thought we could be able to speak to so that more resources could be released to respond to Mpox outbreak, so that the stockpiled vaccines could be released to inoculate our health workers who are in the forefront. To date, 3 years later, not a single Mpox vaccine has arrived on the continent. Yet, of all the cases, thousands as they were, deaths have occurred only on the continent of Africa. Why? Because Mpox in 2020 was small, it did not attract solutions, it did not attract resources. When the outbreak spread to other parts of the world, the stockpiled vaccines were released, and interestingly, travelers were being given vaccines, while health workers on the continent do not have any vaccine to date. When an outbreak is small, as Africa, we are on our own. But when an outbreak is big, like we saw during the pandemic, the same resources are focused on other parts of the world who are better resourced, the global north, for example. So access to diagnostics and access to vaccines are challenged for us where the resources are constrained, but readily available elsewhere. It was very frustrating during the COVID-19 vaccination campaign when it started, for Africa to watch as 12-year-olds in the global north were getting vaccinated, and our health workers who are taking care of people who are unwell, some seriously sick, could not be able to get vaccinated. I hesitated many times to come to the global north, wondering whether it was worth it. When an outbreak is big, Africa is still on its own. This is the unfortunate yet painful reality that we face, not just in Africa, but other resource-constrained parts of the world. Second lesson that we have learned is that due to many factors, including climate change, many outbreaks are zoonotic. The reservoir is in animals, is in birds, and when that interaction continues to happen between the human and the animal kingdoms, and we find the zoonotic diseases jumping into the human population. And this is expected. We have urbanization going on, so we are occupying space that was never meant for humans to occupy. We are pushing the environment a little bit further, and that animal environment interaction ensures that as our habitats overlap, then we get exposed to more and more pathogens. That is why we have regular opportunities for emergence and reemergence and even spread of these zoonotic diseases into the human population. Ebola, COVID, Marburg, all these are just a few recent examples of that particular interaction. In fact, evidence is telling us that more is coming. Are we preparing? Where I said we are not. Are we expecting? Many are, but are still not preparing. That is why us at Africa CDC and the Africa Union, we have taken the very deliberate decision that we are going to work with our colleagues within the animal health sector, within the environment sector, so the One Health approach becomes the focus of our preparedness and our response. We want to ensure that peace times, we are building resilience so that if an outbreak comes, we are able to respond quickly using that One Health approach. The third major lesson, and the final one that I'll share today, is just how unequal the global health security architecture is. And I'll give two examples. Today, 80 to 90% of HIV, TB, malaria, all the cases, they will be documented in Africa. Yet, when we look at the pharmaceuticals that we need, particularly the drugs, we import over 80% of what Africa is actually using in those three major diseases. Who's paying for it? International donors. How much? About 14 billion every year. When we look at human vaccines and we put aside COVID, Africa imports 99% of its human vaccines needs. We manufacture only 1%. When we factor in COVID-19 vaccines, the situation will be even worse. This is not sustainable. In fact, it is not safe for the world because Africa remains heavily exposed and in a way that puts the whole world at risk. And that's why I was saying that global health security, we often forget the word global when it comes to preparedness, resourcing, when it comes to response. That's why at the Africa CDC and the Africa Union, we have decided to do something real and concrete about these lessons that we are learning. Although I've shared three, there are many. The vast majority are very painful. Our heads of states made a call to action last year for a new public health order. This new public health order is guided by the principles of local ownership, local leadership, by equity, innovation, and self-reliance. The new public health order is aimed at safeguarding the health and economic security of the continent as we strive to meet the aspirations of Agenda 2063, the Africa that we want. The new public health order has 5 pillars. The first is strengthening of African institutions for public health, not just public health institutions, but institutions for public health. The reason for this is when you have institutions that address an issue on a daily basis, whether there is an outbreak or not, you're better prepared. You have better data collection. You have more experts that are dedicated to that particular area. Today, in the vast majority of the countries on the continent, even globally, health emergencies, our health workers are mobilized at the time of crisis. When the crisis passes, we go back to our usual life. We don't prepare effectively for the next one. So the first pillar is committed to strengthening these institutions for public health. Africa CDC, the Africa Medicines Agencies are examples at the continental level, but we must also strengthen institutions at the national level as well. Whether they are national CDCs or they are called National Public Health Institutes, we must have agencies that are doing health security work 24/7 throughout the year. We'll be better prepared if we do that. Second pillar is strengthening the public health workforce. The range of experts that we need for effective early detection and rapid response is large. The gaps are huge on the continent. And that is why, as Africa CDC and the Africa Union, we have committed that we are going to train more experts. We are going to give them the right tools, and we are going to deploy them where they are most required. We don't want a health emergency worker doing administrative work, and then during an emergency is when he or she is plucked out of the office to go and do the emergency response. It doesn't work like that. And that is why we end up with large outbreaks that are preventable. So we need to train them, and we need to train them urgently so that they can respond to the emergencies that we have on the continent. The third is local manufacturing. $14 billion annually for only HIV, TB, and malaria. And that's only therapeutics. I'm not talking about diagnostics. Today, the continent does upwards of 15 million rapid tests for HIV. Not a single one is manufactured on the continent. It is a situation that sometimes when I look, I ask myself whether, as humanity, we are really serious. Because if production were to stop somewhere else, there will be no way of knowing what the burden of HIV is on the continent. Manufacturing of health products is our third pillar, and we have started that journey. You have seen manufacturing facilities coming up in new countries. Before, we had about 4 or 5 countries that were manufacturing human vaccines, and a little bit more who were manufacturing other health products. But we have new platforms coming onto the continent. You've seen what's happening in Rwanda, in Kenya, in Ghana, on top of what was going on in South Africa, Senegal, Egypt, and Algeria. So that need to expand local manufacturing is urgent, and it must cut across all health products and not just human vaccines or therapeutics. The fourth pillar is increasing domestic investment in health. We have something we call the Abuja Declaration, where our heads of states committed that 15% of every annual budget is going to go into health. Many countries have not reached that on the continent. And it is because of what I refer to as unhelpful support that comes from donors that introduce a little bit of laziness, if you want, in providing more investment into the health sector locally. The 14 billion I was talking about is helpful, but in the long run, it is sometimes very challenging to ensure that we are getting more domestic investment in the health space. It's something we have committed to do, and we've started that program very actively. In fact, we have a champion in one of our heads of states. President Paul Kagame of Rwanda is the champion for domestic financing. And the progress is slow, but there is progress. We are really looking forward to the coming years when we expand this as we talk about better preparedness for health security. The fifth pillar is to promote action-oriented and respectful partnerships. We know that we must do this on our own as a continent, but we are also pragmatic. We know that we don't have to do it alone. But as we engage in partnerships, those two characteristics are very important. They must produce action. We don't want partnerships and projects that will buy 4x4 wheel drive vehicles, air conditioned and walking through villages without much difference in the health indicators. Those projects are not working unless the health indicators are changing. We want them to be action-oriented, delivering differences, positive differences for the continent. The second characteristic is they must be respectful of the priorities of Africa. We set the priority, and then support can be able to address those priorities. Many health projects on the continent today are based on other people's priorities, whether it is research-based or a philanthropy that is interested in one area of work, yet the priority is in another totally different area of work. It skews the planning, and it skews the allocation of human resource at country level on the continent, promoting action-oriented and respectful partnership. This is our vision. It is our vision to address the challenges that we have identified. It is our vision to avoid the painful experiences that we have continued to experience on the continent. And this is our story. I invite you to be part of our story. We know that implementing the new public health order will require us on the continent of Africa to lead. We know that it will require support from many, both the willing and the unwilling. It will require that all stakeholders, whether it is our member states, whether it is our development partners, whether it is the donor community, irrespective of whether it is academia or research institution, indeed the private sector, including the public in Africa and beyond, all need to work in a coordinated manner to deliver on this vision. We want to, in fact, let me say, we must achieve the ambitions of this vision so that we are a good example of how health security for one is health security for all. And I invite you to be part of this story, engaging with institutions on the continent based on the priorities of Africa. And as I conclude, being shown a little flag at the back there, as I conclude, I would like to end with the words of Nelson Mandela, the African leader and global icon, who said that, and I quote, "It always seems impossible until it is done." And we at the Africa CDC and the Africa Union, we are going to do what may today seem to be impossible. We are committed to implement the new public health order to make Africa safer, indeed, by extension, to make the world safer too. I invite you to be part of that story. Thank you very much.
Thank you, Dr. Ogwell, for your sincere reflections on the value of global health equity as well as global health security. Good morning, everyone. My name is Belinda Clarisme. I am the Executive Director of the Harvard Global Health Institute. At this time, I would like to introduce our plenary session titled The Value of Planetary Health to Global Health Equity. This session was conceptualized in partnership with the Planetary Health Alliance. Giving opening remarks is Daniel Schrag, Professor of Geology and Professor of Environmental Science and Engineering at Harvard University. Also the Director of the Center for the Harvard Center for the Environment. Professor Schrag, please take it away.
Thank you. Thank you. It's so nice to be here this morning. So I'm a climate scientist. I'm not a physician, but I've had an engagement in global health really since I first arrived at Harvard 26 years ago. 1997, I came here, and in the spring of 1998, my first course I taught at Harvard was a course on climate change and health, taught with Paul Epstein and Jim McCarthy. It was a ESPP seminar. And I'll tell you, it was a struggle. It was a little bit of a struggle, and I think that struggle continues today. Around the university, climate change is a big thing. And climate change and health appropriately is getting a lot of attention. And yet it turns out that defining what climate change and health really is about is a difficult challenge. And I think one of the reasons is really highlighted by this session on planetary health this morning. You know, how can you think about, say, the impacts of climate change on infectious disease in a place like Malaysia if you don't notice that nearly 30% of the land area of Malaysia has been deforested for palm oil plantation? how can you think about the hurricane damage in the Caribbean and islands in the Caribbean if you don't understand the devastation to the fish population and how that's affected nutrition and diets and created all sorts of new health vulnerabilities, like diabetes and other issues? Or I was just in Delhi 2 weeks ago. How can you think about impacts of heat wave on Delhi, in the population in Delhi, without thinking about the air pollution that's really among the worst in the world? All of these things are interconnected, and I think that is what planetary health tries to address. That's the vision that was really put forward by Sam Myers and others many years ago. Sam is the founder and director of the Planetary Health Alliance, and we're very fortunate to have him here organizing this session. And with no more introduction from me, let's move on. It's my pleasure to introduce the panelists. Jamila Mahmood, she's professor and director of the newly established Sunway Center for Planetary Health in Malaysia. Mandeep Dhaliwal, director of UNDP's HIV Health and Development Group. Courtney Howard, who's an emergency physician at Yellowknife, the place I was just before the pandemic, and a clinical associate professor in the Cummings School of Medicine at the University of Calgary. And of course, Sam Myers, who's a physician and principal research scientist at the Chan School here at Harvard. Please, our panel, welcome.
All right. Well, wonderful to be here with all of you, and thank you to the Harvard Global Health Institute for having us. And I think Jamila is with us, and hopefully will be up on the screen in just a minute. I think a lot of you have probably not yet been introduced to the whole sort of framework of planetary health, and we'll give you a little bit of an introduction to that. But before laying that out, I just wanted to go right to our panelists. We have an amazing group of global leaders in the field of planetary health, but really in global health more broadly, who've all had just incredible careers in different ways and different geographies, and maybe even slightly unpredictable career paths that are incredibly rich and illustrative of, I think, the issues around global health and equity. So with no further ado, I think we should start out with just asking each of you to introduce yourselves to our community here, talk a little bit about just your own professional journey, how you got to where you are today, and how planetary health has become a meaningful frame for the work that you do. So maybe we should start with Jamila, who is joining us all the way from Malaysia. So it must be late at night. So thank you in particular, Jamila, for taking time in your late evening to join us. And let's start with your initial comments.
Thank you very much, Sam, and hello, everyone. It's a real pleasure to be here, and of course, I'm deciding to join you virtually because of my very close watch on my carbon footprint. I'm a obstetrician and gynecologist by training, but for the past more than 20 years, I was a humanitarian worker, working in NGOs, and then later on the United Nations. And then my last international job was at the Undersecretary General of the International Federation of Red Cross. And you know, in my entire humanitarian career, I've worked in so many different emergency settings, but climate change has really, you know, made me question whether a lot of the work we're doing as humanitarians are, you know, the metaphorical band-aid on gaping wounds that we're facing. And if I can relate a very personal story, when I started my career, there was a terrible flood in Mozambique in early 2000, I believe. And I still remember vivid images of a woman on a mango tree delivering her baby and clinging on to that child with one hand and the other onto the tree before a South African rescue helicopter, brought her to safety and the baby. And fast forward about 19 years later, just before the pandemic, started to rage, I was back in Mozambique after a terrible flood again. And, talking to people then, playing with children who were affected by the floods, I came to realize that, they hadn't improved in the conditions. The climate change had exacerbated more severe floods. And to my alarm, I met a child who told me through his mother that she had to give birth to his sister in a tree. And I really, it hit me really hard, particularly because I'm an obstetrician and gynecologist by training, that, health equity doesn't exist in many countries in the world. And the well-being of people are being very severely compromised by a lack of approaches to look at, the integrated, multi-sectoral, multi-systems approach that's required for us to deal with severe situations that are being, right now in front of us, primarily as a result of climate change. And that's when I, got really interested in planetary health. And I live in Asia. I came home to Malaysia after the pandemic. I left my job in Switzerland because I feel so passionately that Asia, being really an epicenter of so many climate disasters and also infectious disease outbreaks, we need a new paradigm. We need a shift now to looking at planetary health. And so far, the center is quite new. It's barely 2 years. But I can proudly say that already Malaysia is looking into developing a national planetary health action plan. So it's slow and steady progress, but we need to now call for political, social, economic, environmental shifts in how we actually do things for people's health and equity. Thank you, Sam.
Fantastic. Thanks so much. Mandeep, can you tell us a little bit about your journey?
Thanks. Thanks, Sam. And I'm an infectious disease doctor and a human rights lawyer and have worked in HIV for over 4 decades. So the concept of equity and community engagement are very real to me. So it's a real honor to be here today. And I came to Planetary Health in about 2016. And I have to pay tribute to my colleague Natalia Lenou, who's here today, who actually planted the seed for the work within UNDP in 2016. And as time has gone by, it has become clearer to me that it's really the kind of transformative approach that we need to deal with the complex and interconnected crises that we see in the world today. And what's really striking about planetary health, and maybe we need to make more of it, is that equity is at the heart of it. And we've seen from HIV, we've seen from other disease responses that unless you really, really focus squarely and prominently on the issue of equity, it doesn't happen by accident. It has to happen by design. And I think that's really, really what we're seeing. And, we heard from the keynote speaker, so many inequities in the response to COVID, inequities in access to science, inequities in just access to the, vaccines, resources. And so these are the things that we simply cannot accept and tolerate going forward. I mean, you just have to turn on the news. We heard about the accelerating number of outbreaks. The climate emergency is probably the biggest public health emergency of our time. And single sector solutions are just not going to cut it. And I think that's, at UNDP, we work on the determinants of health, and we talk a lot about multi-sectoral responses, supporting countries and communities to address the determinants of health, social, environmental, economical. But economic, what we realize now is that we need to go beyond multi-sectoral, multi-system now. We need a radical shift. We can't keep doing what we've been doing. And we have a blueprint, and Sam and I always have a debate about whether this blueprint is sufficient, the SDGs, Sustainable Development Goals, which are really about an integrated agenda, which I think resonates very strongly with the planetary health approach. But the part of the SDG agenda that gets the least attention is the pledge to leave no one behind. And beyond that, to reach those furthest behind first. So I think if we're thinking about equity, health equity in today's world, we really have to look at those who have been left furthest behind first and start there. So that's kind of, I think one of the paths to the transformative approach that we need. And, this transdisciplinary approach and framework that planetary health provides is the way to look to the solutions for the future for the world that we live in today. Thanks, Sam.
Amazing. Thank you. Courtney, tell us about how you got here.
Thank you. So I actually came to Planetary Health initially because I wanted to work for Doctors Without Borders. And they said, okay, so you've graduated from McGill University, you're an emergency doctor, you know how to work in a big center. We need people who know how to work in more rural, remote areas. You need to go to the north of Canada. So I went up to Nunavik, which is north of the Arctic Circle, and I didn't have a book and it was the winter time. So I picked up a book, like actually at a run in the Edmonton airport, and it happened to be on climate change. And I was a new grad, and I was quite embarrassed because I'd been spending, I'd spent decades in study carrels and hospital call rooms, and I actually couldn't talk about anything other than medicine. So I'd go to people's houses and they'd be like, and what about the situation in Croatia? I was like, I haven't really paid attention since Yugoslavia was the country. And so that was a concern to me. And so I actually started a folder on my computer called Geeky Learning About the World, and I just started reading more broadly. And so I thought climate change was something that a responsible adult should learn about. And so I ended up reading this book on my way to Nunavik, and I finished it in a hospital that actually sits on permafrost. And because I know that PubMed is a good place to learn about things, I ended up reading Costello et al.'s 2009 report in the Lancet, the first Commission on Climate Change and Health, that said that climate change is the biggest health threat of the 21st century in a place that was 3 degrees Celsius warmer than it was when an 80-year-old elder was born. And so that was a really quick route from lack of awareness of the problem to really central in my vision, because when I looked up and I asked my patients, this is the junction of Inuvialuit, Gwich'in, and Dene territory, and people there, the most healthy food comes from the land, and in order to access it, a lot of the time you have to travel on water. And 3 degrees Celsius is a really big difference between water you can walk on and water that you're very much at risk of falling through. So this had consequences for food security, for mental health, for cultural sharing practices. And when I then went to the Canadian Medical Association, Canadian College of Family Practice, et cetera, at the time, this was 13 years ago, people were not paying attention. And I was lucky that I did work for MSF. I resuscitated malnourished children in Djibouti for 6 months and had children die under my care, which is not something that happens a lot as a doctor in a high-income country. I've now been an emergency doctor for 15 years, and I've only had one child die under my care in Canada. And standing at the bedside in Djibouti at one point, there was a heavy rains, it polluted the water supply. We were having children who arrived having already recently passed away. And I had a moment where I was just so full of rage that I couldn't see. And I said to myself that when I got back to Canada, I would do everything I could to prevent further similar deaths. And I didn't know what that meant at the time, but when I came home and realized that climate change is the biggest health threat for these children, pediatric malnutrition is one of the greatest health threats of climate change. And I lived in a place that had one of the highest per capita carbon footprints in the world. If I really wanted to prevent those deaths, I should stay home and work on decreasing Canada's carbon footprint. So that's what I've been doing since then. And I've lived in the subarctic since then. We're downstream from the oil sands. There's lots of local toxic impact as well. But really, I think one of the things we can offer in planetary health is because it helps to connect those dots. I didn't realize when I started doing that, that's a way of decolonizing planetary health and global health. And what it requires is that you stay home and confront the power there, which is uncomfortable in a very different way.
Fantastic. So many of you are now, you've got these little snippets of amazing stories and rich experiences, but you're probably still maybe wondering, so wait, what is planetary health? And are we talking about the health of the planet, or, I hear a lot about climate change. And so I want to just give you a sort of 2-minute primer on what we actually mean by the frame of planetary health. The sort of core precept of planetary health is that the size of humanity's total ecological footprint has grown so much in really just the last 4 or 5 decades that it now exceeds our planet's capacities to absorb the waste that we're producing or to provide the resources that we're using sustainably. And as a result, our own activities collectively are transforming not only the climate system, although that's very important, but all of the natural systems on the planet, driving the 6th mass extinction of life on Earth, changing land use and land cover, driving scarcity of resources like fresh water and arable land, driving global scale pollution, as Dan mentioned, of air, water, and soil, and that all of these human-caused global environmental changes, which are accelerating, are actually interacting with each other in very complex ways that we're just starting to understand, but that affect the foundational qualities for human health and well-being. The quality and quantity of food that we produce, the quality of water that we have access, the quality of air that we breathe, our exposure to infectious diseases, exposure to extreme weather events, even the habitability of many of the places that we live. And so as a result, we are now seeing growing global burdens of disease across every dimension of health, not just infectious disease, but around nutrition, mental health, non-communicable diseases, population displacement and conflict. And so fundamentally, how we are living is transforming the natural life support systems that we depend on and then affecting our own health. And if fundamentally the diagnosis that we're making of the moment we're in is that ultimately, and really without hyperbole, we're choking the life out of the planet. I mean, that's what it means to be driving the 6th mass extinction of life on Earth. And our own lives are in that same bucket. And if the diagnosis is that the way we are living is actually imperiling our own health and the rest of life on Earth, then the treatment has to be to change the way we're living. And so we talk about this idea of a great transition, the need for rapid, deep structural shifts in how we live across all of our systems, food systems, energy systems, manufacturing and circular economy, built environment, that we really need to figure out how to reduce that ecological footprint around the world to protect and regenerate the natural systems that we depend on. And so that's the sort of big picture. And when Mandeep talks about transformative change, that's the scale of transformative change that we're talking about. And it actually starts to beg the question, what does it even mean to be a health worker? Do we need to expand the concept of a health worker much more broadly and to include this need for a transition in how we're living really across the board? And so I want to go back to our speakers, and we've talked a little bit about how you kind of came to this diagnosis side and to understanding climate and other dimensions of environmental change are really problematic in different settings around the world. As we move to the sort of treatment or the action side, Jamila, you mentioned right at the outset that you've been working on this Malaysia Planetary Health Action Plan. You're also hosting the next Planetary Health Annual Meeting there at Sunway Center in Malaysia in 2024 in April. And I know you're thinking about a year of action. And so action is always, I know, front of mind for you. Can you talk a little bit about how this planetary health framework changes how you think about the action that's needed to secure global health?
Thank you, Sam. I think that without a doubt, the evidence is clear, and scientists and academicians have really done a fantastic job in trying to bring that evidence forward. So we often have to ask ourselves, then why aren't things changing? And, confronting that reality, that turning evidence into action, what is the missing bits? What are the missing bits that we need to look at? And for us, it's really looking at how we drive or look at governance. The second thing is around, what kind of communications is now needed to change, policies and to shift mindsets, because ultimately it's about behavioral change and the Anthropocene. And the final thing is we're also looking at what kind of education is required. What education revolution do we need? Not just general education, but medical education. Till today, climate and health is not a consistent topic taught in all medical schools. So in trying to to conduct this next Planetary Health Annual Meeting, what we want to do is from May, through the regional hubs that we have in the Planetary Health Alliance, to start conversations around what does it take to drive a great transition, and to come up eventually with a draft global roadmap. So whoever you are, whether you're a policymaker from the government, or you're an NGO person, or health worker, academician, business person, and bringing different stakeholders into the room, because often we are in an echo chamber, we talk to the converted. So this meeting is trying to change it, trying to be a bit different, to really have, you know, a solid, hopefully a kind of roadmap that all of us can take home and look at and say, okay, this is maybe what I can do to start shifting, you know, evidence to action, because this is what we badly need. You know, we've seen all the different international global meetings, and still, you know, temperatures are rising, pollution is increasing, you know, climate change is not abating. And, you know, what does it take now for the right policies and ultimately right political decisions?
Thanks, Jamila. Mandeep, any thoughts about how all of this sort of understanding changes the kind of actions that you're thinking about at UNDP?
Was just very inspired by Jamila's really structured way of dealing with, you know, of responding to your question. And thank you for moving us past the diagnosis, because I think we're often stuck in just diagnosing the problem and debating the evidence, and there's really no time for that anymore. I think the two things at UNDP for me, which are really, really interesting that we can bring to the table, are really connecting the climate, health, and environment work through our organization. We have one of the biggest portfolios of climate projects in the United Nations. We also have a huge health portfolio that, you know, through partnerships with WHO, the Global Fund, UNAIDS, and now PEPFAR, and really move the discourse on communities and equity. And I think that's the way to do it. To move from community engagement to community leadership, that means giving resources to the communities to, for example, be able to detect outbreaks when they happen and prevent them from becoming epidemics or pandemics. So moving from community engagement to community leadership, I think, is one. The equity lens is really, really important for us at UNDP. And I think this reaching those who are left furthest behind first. I mean, we see it in everything that we do, that it's the poor, the marginalized, the criminalized in the context of HIV, who bear the disproportionate burden. So let's start there. Let's not start with low-hanging fruit, but start with those who are bearing the disproportionate burden. And I think that, for me, is a way that we can, because communities are experiencing these things. They don't live in the HIV silo, TB silo, and the climate silo. It's all lived experiences, all, you know, so they respond in a way that is interconnected already. And I think it's really resourcing that and helping to scale that up. The policymakers and the political decision-making is really important. I think we're at a moment where we can really push for transformative change, because people realize that existing siloed sector-specific solutions just aren't working. So if we're gonna meet the moment, we really do need, you know, something that is truly multi-sectoral, and something that's truly integrated in the way that the planetary health framework pushes us to think and act. And so I think the integrated action is more important than ever, and that's how we move things ahead now.
Fantastic. And Courtney, what about you? I mean, you've been on a really amazing journey. You've run to lead the National Green Party in Canada. You've gotten engaged in movement building. You've been organizing among emergency room physicians globally. You've taken a lot of different hacks at this problem from different dimensions. Where are you now in thinking about action?
Thanks. Yes, I've comprehensively experimented along what I now regard as a spectrum of treatment for planetary health emergencies. So there's research, we need the basic research, and that there's inequities in the research. I'm downstream, as I mentioned, from the oil sands. There was a big tailings pond leak there recently, right into the Athabasca. Giant river comes all the way north. This empties into the Arctic Ocean eventually. No one has ever done a decent community-based study that includes traditional knowledge into the local health impacts of the oil sands. And that is a situation occurring in a democratic, high-income country. So you can imagine what this looks like in the Delta in Nigeria, right? And so these communities are left without any numbers, without a voice, without anything to bring to the table to say, look, we need help and we need you to start costing out this pollution and asking the polluters to pay. So research, where are the inequities in the research? Who can be best helped? And how can we partner with those communities so that we can, as was mentioned earlier, have their priorities be first? Policy, I wasn't taught anything about policy in medical school. I was lucky because I found my people early. I went straight down to the Canadian Association of Physicians for the Environment table at a family medicine conference and actually met their founding president. He said, do you want to sign up for our mailing list? I said, I want to do more than that. So I showed up at their board meeting. I didn't know anything, but somebody stepped off the board. I was the only other person there at the time, so I stepped on. So that was 13 years ago. And I was willing to learn. But what happened was I showed up and I said, we need to fix climate change. And Gideon Foreman, who was their executive director, who came from environmental campaigning, said, well, what's your target? And I said, what do you mean, what's our target? He said, you need a target. I said, we need to fix climate change. And what I was expressing there, which I've now read a lot about, is a default information deficit model of change making. I didn't know I had that. I think our whole sector doesn't know that we have that. What he was telling me, coming from a different place, is like, look, this is a big problem. You've zoomed out. Now we need to zoom in, pick a target, build the team, assemble the resources, figure out who's in charge of making that thing happen, put pressure on them at a specific time through a specific set of tactics, and make that happen. And eventually he figured out the target. So what he decided to do was lend the voice of health to efforts that were undergoing at that time to phase out coal-fired power in the province of Ontario. So we did. So we partnered with community groups. We talked about clean air. We had physicians with stethoscopes around their necks, scrubs, et cetera, saying, hey, we don't want to have kids in our emergency department with asthma. And there's another way of doing this. We had engineers working with us. We had an alternative plan. We knew how much it would cost to switch. That worked. When the last coal-fired power plant in Ontario closed, it was the single largest greenhouse gas reduction maneuver in North America. We essentially used the same game plan to get a commitment to accelerated coal-fired power in our most right-wing province, our most conservative province of Alberta. It turns out that nobody wants to have kids in the emergency department with asthma if they don't need to. We went then, same thing, nationally, got a commitment to an accelerated coal power phase out in Canada, and that let Canada co-found the Powering Past Coal Alliance with the UK, which is now catalyzing work internationally. And at the most recent climate change negotiation, I was super happy to be able to introduce the Secretariat of the Powering Past Coal Alliance to the leadership of the Global Climate and Health Alliance. I was on its founding board, and say, hey, let's do this. Let's scale this internationally. And the thing is that when you think about that, I think sometimes we expect this work to be done by someone magical that's not us. And those people, I can tell you, have no resources. So when you think about like what I just described, that requires research, it requires the production of reports, it requires media training, it requires a tremendous number of meetings with government, it requires being able to show up at a given time prepared in order to present your case. We are not funding that. And so if we think this change is going to happen without moving resources to fund the institutions to help people do work that is risky. I did Marshall Ganz's movement building course last year, and he talks about how creating change is a practice. You can't really learn it without trying to do it. And he says that the reason people don't want to do it is because there's the potential you might lose. You know, I've described successful campaigns. We don't win all of them, and we certainly don't win them the first time. We got the Canadian Medical Association to divest from fossil fuels, but I showed up 5 times before anything happened. But every single time you make relationships, that leads people to help you with resources, your team builds. And really what I've learned, I'm doing a policy degree this year, is that there's a bandwagoning effect. Once you start to do concrete things, people see, they're inspired. They're like, hey, I want to be with that team. That looks exciting. and then they add their resources to yours and your team builds. And so I think really moving from this information deficit model of change to a targeted model of change, funding the structures, like what we've gotten done with minimal resources has been incredible. Imagine what we could get done with all of the smart people in here figuring out, okay, which communication specialists do we need to talk to? Which campaigners do we need to talk to? Who's the best person we know at influencing political change and making sure that some of what we have to offer, a pretty big chunk of it, gets funneled over there. So research, policy, advocacy, political interventions, that's the spectrum, and we need to make sure we support all of it.
Fantastic. So one of the things that I'm hearing that resonates for me as a sort of confused physician who's strayed pretty far from my own roots is that as you start to recognize that some of maybe the greatest drivers of burden of disease into the future are going to be environmental changes and disruptions in natural systems, that there's this steady kind of redefinition of what it means to be a health worker globally. I want to stress, equity's come up a bunch in this conversation, obviously an overarching theme for this whole meeting, but it needs to be said explicitly that this isn't only about addressing problems and making sure that we start with the most vulnerable. This is about recognizing that the way that we're living collectively is such that the wealthiest people in the world are far and away the most responsible for driving the kind of environmental change we're talking about, whether it's climate change or biodiversity loss, et cetera. And that we, by and large, the wealthy part of the world, accrues most of the benefits associated with the activities that are transforming the global environment, while the burden of that transformed natural system, of those lost life support systems, is borne by the poorest people in the world, by people of color, by indigenous peoples, by future generations, by non-human beings, right? And so there's a huge disproportionality around who's benefiting and who's bearing the burden. So right in the core of the issue itself is this massive inequity. And so, of course, we need to be thinking about the most vulnerable populations, but we have to acknowledge that actually the way we're living is putting the poorest people and future generations in harm's way, and there's something profoundly unfair about that dynamic itself. I think the other thing that I'm hearing that I think is so interesting is this expansion into building power. That, if we say that, well, the major drivers of global health now include our transformation of natural life support systems, then trying to fix that becomes an important part of what we need to do as global health practitioners. The good news is that the most respected messengers in the world are health practitioners, nurses, year after year, the last 17 years, both nationally and globally, doctors somewhere down below nurses, that we carry a message that actually resonates more than almost any other message around global environmental change, which is we need to address these problems to safeguard a livable future for your children. So we are trusted messengers carrying a compelling message, and we touch just about everybody on the planet, regardless of political affiliation or geography. And so this is an enormous sort of untapped resource in the global health community that we represent to take on some of these challenges the way Courtney's describing. The bad news is that particularly doctors, I think much more than nurses, are terribly trained to actually take on that responsibility. We're not used to working collectively. We're not used to building power. We want to be sort of right in the middle and be the heroes in the story. And that's not how movement building and action works. So when Courtney talks about the knowledge deficit model, I think, the point being that the real problem we're facing is not actually a knowledge deficit, that we actually understand a lot about how global environmental change is affecting health. The real problem is what Marshall Gans would call a power problem, that we actually need to address the fact that there are entrenched industries and interests that are trying to maintain the status quo, and that to address that kind of a problem, you need to build power, and to build power, you need organizing and collective action. And so again, this sort of additional expansion perhaps of what it means to be a health practitioner. So I just want to be a little provocative and throw that out there. But I want to go back to Mandeep, because you mentioned the SDGs. And in terms of action, what I've heard from all three of you is the word integration. I think it comes when we think about the metrics of what does progress mean, that we need more integrated metrics. It comes when we think about the actions we want to take, that we need to address health, but simultaneously be thinking about how we maintain natural systems. But when you think about the sort of next sort of post-SDG framework where there's a lot of action starting to happen, how might planetary health be relevant in that sort of post-SDG framework, do you think?
I think it's very relevant because, we have the SDG framework and, the communication around it from the beginning, from 2015, was all about we need integrated approaches. It's an interconnected agenda. Sector-specific or goal-specific actions on their own won't be enough to deliver on the agenda for a whole host of, economic, political, social reasons. And that was well accepted. You hear a lot of people talk about it. But things didn't change. We didn't organize differently. We were still organized, from the multilateral system on down in specific silos, mirrored at the country level in ministries that are specific silos. So what are the incentives and the frameworks that can drive the integrated action that's needed? That has to be part of the discussion for the agenda for the future. I mean, the Secretary General is doing a series of ministerial consultations this year in the lead up to the Summit of the Future, which I think will help us think through what that blueprint looks like. And if you look at his, the initial kind of agenda he's put out, our common agenda for the consultations, it is very much about integrated approaches, about emergency preparedness, about how do we deliver universal health coverage in a meaningful way? How do we address some of the crises that we're seeing for planetary health? So I think there is an absolute place for the framework. I think we have to show, we have to go beyond the description of the framework to show how it's being actioned. And I think that's where what Jamila is saying and what Courtney's described, we need to maybe capture more of that to feed into the discussions in 2023 and 2024 to really drive that, drive forward planetary health as an approach and a framework that can help us to be better prepared, even in the multilateral system, to actually help countries respond to, the great challenge that we have.
Thanks. Yeah, we've talked a little bit about, I don't know how many people here are familiar with Johan Rockström's work at the Stockholm Resilience Institute, but he sort of popularized this idea of the SDG wedding cake, but it's this sort of concept that there's actually a little bit of a sequence or a hierarchy in thinking about the current SDGs, where there are a core set of SDGs around stabilizing the climate system, around protecting marine and terrestrial biodiversity, around clean water, that are really about stabilizing the biome. And that he put those at the base, essentially arguing that we're not going to effectively address, poverty or health or, the sort of core human needs that we have to address without stabilizing these foundational life support systems. And then he layered those SDGs on top, and then the things like peace and equity and income generation, some of those things that are sort of like they require addressing hunger and poverty, and so there's this sense of a hierarchy. And I guess I'm curious, whether there's thought about introducing that kind of a hierarchical or a sense of the foundational importance of protecting the biosphere would be one question. The other thing that has come up time and again is that if you have 17 SDGs in all of these different sectors, you can actually celebrate success in one dimension of progress, which is coming at the expense of other parts of your goals. And that doesn't really make a whole lot of sense. So how do we create sort of integrated metrics that are asking, can we produce enough nutritious food to address, the hunger and nutrition challenges without increasing the ecological footprint of our food production system or things like that? And I'm curious if those ideas are making it into the...
I'm going to take a liberty here and just say something about, the tyranny of the economists. And I don't know how many economists there are in the room, but I work in an organization that is overrun with economists. And I find this conversation about trade-offs has gotten us into the mess we're in. Because there are trade-offs, and I think people talk about them quite explicitly. And I think we need to move from trade-offs to synergies and tipping points. And that's the conversation that needs to happen around the SDGs right now, is where is the synergy and the tipping point the greatest for us to be able to transform the health of the planet and the health of people at this point, rather than the trade-off question. Because the trade-off question is the economic point of view, and it's created, and I think it's largely responsible for the mess that we're in right now.
Yeah, no, that makes sense. I see we may have a few extra minutes, which is great. So yeah, about 15 minutes before we wrap up, I'd love to ask Jamila to jump in on this last sort of strain of the conversation, but I think we'll also have a little bit of time to ask you all for questions. So be thinking if anybody has questions for the panel. And Jamila, I'd love to hear your thoughts about this question of integrated metrics and development.
Yeah, I think that, that's a really important question, because let me go back to SDGs. I think without a doubt, the world came together in an intergovernmental process with a wide consultation beforehand to agree on a direction of travel and set, a bunch of goals. But as Mandeep said, the ideal was the integration, but the reality is the silos. And this happens in the medical profession as well. I think this is why, I keep saying that we have to step up, right? I think that planetary health offers a framework where we try to break those silos. And it also requires a lot of courage. A lot of courage to actually say we have to do things differently. People like Courtney, myself, you, Sam, and Mandeep, we keep plowing on because we truly believe in the potential of achieving things if people actually get their act together. And I think this requires us to really target behavioral science. And this is why, I'm fascinated by planetary health, because it's really about the Anthropocene. It's about our individual behaviors as individuals, as leaders, as policymakers, as politicians, as corporate leaders. How do you change the way you make those decisions? So that's why, I truly believe we don't have much time, because the planet is really at a very difficult point right now. And if you have seen Johan and Joita Gupta's presentation on the 16 tipping points, and it's very worrying what we're seeing in the Antarctica and so forth. But, we have to persevere. And I just want to say, since I'm speaking to esteemed, medical professionals here, health professionals, we have a moral duty to raise our voice. I remember speaking to Rosamund Kisidebra recently in London, whose daughter Ella died 10 years ago due to toxic air pollution, and remains the only person in the world with toxic air pollution on her cause of death in her death certificate. And she asked me a question I couldn't answer. She said, "Why aren't you doctors speaking up? Because you are the most trusted people in the world. Why aren't health professionals speaking up?" And when I think about it, Ella could have been anyone we knew, a child who struggled to breathe as a result of air pollution.
Thank you, Jamila. Any questions from the audience, or I don't know if we have a way of getting questions from our virtual audience? Before that, and while we're getting that organized, Courtney.
Just while people are thinking, just on metrics, there's international metrics, there's also national metrics. So I did, at the beginning of the pandemic, I knew we were going to spend a bunch of money. I felt like a planetary health frame would help Canada maybe spend it in a way that would be helpful moving forward. So I ran for the leadership of the Green Party of Canada as an emergency physician and mother in the middle of the pandemic. Why? Good question. However, what that meant was I did a literature review on things I would never, ever have looked up before. And so I got deep into the ecological economics literature, which is not what you're supposed to do during a campaign. You're supposed to be fundraising, so pointer for next time. However, GDP makes no sense. It was never designed as a measure of national well-being. It has probably utility, but Jamila, that started basically a pathway for me. I'm at Oxford right now doing a policy degree so that I can start to understand how the economists are actually thinking. So I've learned from conventional economists, but been lucky with Jamila to spend quite a bit of time with Kate Rayworth. They have a power issue within the economics faculties, because the people who've been doing it the way it's always been done have all the power, and they need help. They need voices from outside pulling out the ideas that are going to save our ecological foundations. And we know from all the communications literature that that's probably us. We're probably best placed to do that. And so what that means, I loved what you said early on about changing the definition of healing. You know, if all of us can contribute to stabilizing our ecological foundations and contributing to a healthy future, that means that we can work with economists and say, hey, your work saves lives. You know, we can work with engineers. I work a lot with an engineer, and he knows that his work is helping to save lives. And so we're at a moment where people are in transition, looking for a path forward and a why. Planetary health offers that, and it prevents us from having that stay in your lane commentary. I don't say the economics. I go and I present with an economist, and I give the why, and then I'm like, listen to Doug about carbon pricing, and it works really well. So what I find is this work does take courage, and community is what gives us that courage.
That's a great point, and that's one of the reasons why the Planetary Health Alliance has just joined with the Wellbeing Economies Alliance, moving forward, as this sense of sort of economic reform is right in the middle of all of this. I mean, you know, what you're hearing is sort of the story of the onion, and it's many, many, many layers that as you start to think about these problems, they sort of ripple out, and it's hard to find the end of sort of the domain itself, because it ends up connecting to sort of everything if you're realizing that the way we're living is actually causing the health problems that we're facing. But let's open it up for any questions.
I guess I should stand up. Thanks for the discussion, and just really appreciative of the different ways and different aspects and different angles that each of you bring to the conversation. I'm just curious if there's a conversation, or kind of where the conversation is, especially amongst the health world, on acknowledging the drivers that have gotten us here, and more of a restorative justice or truth and reconciliation approach to planetary health. I think in medicine, we often start with the current problem and don't always get back to the roots. And so I've seen a lot of conversations around racial justice in the climate change work, and conversations about how colonization has driven, you know, the planetary crisis that we're in right now, or the climate crisis that we're in. Where is that conversation in the planetary health conversation? Are there people saying, you know, this is how white supremacy has created this problem, or this is how colonization has created this problem, and kind of where do you see that going? And it ties to the panel this afternoon. So,
fantastic. Anybody who wants to jump in? I mean, I will say just for a little small piece of this, that at the Planetary Health Alliance, you know, a couple of things. The Global South community makes up the majority of the members of the Planetary Health Alliance, and that Indigenous voices have become really, really important in our community, not out of some sort of nod so much to their kind of vulnerability, which is real, but out of a respect for the wisdom that comes from those communities with respect to the kind of interconnectedness and reciprocity that planetary health is really speaking to. And so the need to inject that knowledge and that understanding into the community as we think about solutions. It's also, you know, one of the things we haven't talked about, and again, it's another layer of the onion, is if your core argument is that there's an Earth crisis, and that underneath that Earth crisis is this global health crisis that the Earth crisis is precipitating. I think that underneath all of that, there is a spiritual, sort of emotional crisis, a crisis of meaning, that something is fundamentally broken in the relationship that we have to the natural world and to each other. And that sort of paradigm of kind of domination and extraction and colonization is actually highly relevant to all of the issues that we're talking about. And so we have had this interest through the Constellation Project in this question of, can we begin to think about the other stories that we could be telling about those relationships? And it's something that Terry Tempest Williams and I started out, but it's really broadened to a much bigger community, and it sort of speaks to the critical role of the arts and humanities, to indigenous knowledges, to faith traditions, you know, in this conversation. So again, another sort of layer of that onion. But I'd love to hear thoughts from any of you as well.
I mean, I think it's a really important moment in time. You know, we had, coming out of COP27, the Loss and Reparations Fund, and I think there's an understanding that is becoming much more concrete in terms of response around, you know, common but differentiated responsibility. And what does that mean? So I really think that there is a very powerful opportunity, and again, through the Planetary Health Framework, which, you know, I think provides a very, and as you say, the Alliance is largely Global South, to bring those voices to the table to say, okay, well, so, you know, what does that mean? You know, how are we going to repair things? And really kind of connecting the dots around these issues of justice, of decolonization, of anti-racism, of the climate crisis, the public health crisis. So there's, you know, the integrated conversations are happening more and more, and I think they're becoming more meaningful and more concrete.
And I think our key to our approach, Nicole Redvers is from where I live. So I met her, she's originally a naturopath, now doing her, she's got a master's, and she's doing her PhD at Oxford in decarbonizing health systems from an Indigenous perspective. But we first met over lunch in Yellowknives Dene Territory, and what she and everyone else there, because I used to go to the Canadian Medical Association General Council and basically get yelled out of the room. And I would come home and I was like, I'm pretty sure the Lancet said this was a problem. Like, am I wrong? And people like her, people like Elder Francois Paulette, people like Elder Bessa Blondin would say, no, doctor, keep going. And my kids, because it's a majority Indigenous place where I live, our premier is Indigenous, my member of parliament's Indigenous, so we have some structural things that have changed that show me the way things can be. So when my daughter went to school and got her first report card in kindergarten, it was numeracy, literacy, connection to the land. And I burst into tears. And that is threaded through the curricula. So they like, she'll get, Elodie appreciates fall and what it tells us about the changing of the seasons and the cycle of life and death. And so I didn't, again, realize that I was working with what is referred to as an ego-based model of the world, which has sort of humans in domination with men at the top. and that what we really need is an eco-based model of the world that has us all part of a circle and in relation to one another, which makes so much sense. You know, when we start as doctors, and what we do get taught about is the relationship between all of our organs in terms of physiology, and then we graduate for a while and it turns out there's a microbiome we need to think about that also has all sorts of interconnections, and this is the larger biome that we're also connected to. So I now view planetary health as, and you know, when you go to something in Yellowknife, they talk about our relations, the four-leggeds, the winged animals, et cetera. And it really does feel like we're all part of an ecosystem and we need to take all of those into account. So really, living where I've lived has completely rearranged my worldview and therefore everything that I do. And so I think these conversations, as you said, it's not only about, you know, reparations and injustice, although that is, you know, where I live, some people both got abducted by the medical system to be put on a TB ship, and then also got abducted to go to residential school, and when there's epic trauma associated with both of those things, but the wisdom has remained, and how we can use that wisdom to help us build a better world for everybody in order to rework some of the systems that led to those inequities in the first place and undo them, I think is one of the more beautiful parts of the work.
Thank you so much, Courtney, beautifully said. We're running down to the wire, so we have about 2 minutes.
Can I say something about
so
trust? Because
everybody's gonna say 45 seconds of closing thoughts. We'll start with Mandeep.
Okay, I didn't know that was coming. So, but I will use this space to talk about trust. And I think we live at a time when trust in institutions and governments and in some societies in each other is really, really eroded. And eroded by technology. Even like the erosion of trust is accelerated by technology and the overuse of technology in our lives. I really think the role that health workers can play, and when I say health workers, I also include community health workers in that, in restoring trust and really using our trust in a responsible way is very, very important. And you're absolutely right to call that out as an important call to action, I think, for all of us.
Thank you. Jamila?
Yeah, I totally agree with Mandeep, but I'm going to say that sometimes the problem looks so huge and hairy that it's so hard and you get overwhelmed. But I think we also have to think very locally. What can be done locally? How do you build a movement of change? And, you'll be surprised that, some things might start to move. I believe very strongly that, this is the way forward. Really, governance and governments, are slowly losing a lot of trust, as mentioned before, but many things can be done at local level. So, based on what Courtney was saying about Kate Rayworth's donut economics, we are already piloting it in a city in Malaysia. And, it's just changed a lot of the policymakers' minds. They get excited about, bottom-up approaches and how you look at decarbonization and letting people live a better life. We cannot let this horrible pandemic we've just been through go to waste. It's a real opportunity now to have these conversations and to put action on the ground. So at the end of the day, let's not rely on big meetings and big goals, but start putting into action, even at a clinic level or your interactions with students, start having these conversations.
Thank you, Jamila. And with very little time left, Courtney, any last thoughts?
Yeah, thanks. It's a moment of huge risk and also therefore huge opportunity. What we need to do is rearrange our incentive structures, channel resources to different parts of institutions, and be brave. So if you're feeling scared, what you need to know, I've done word clouds on this in classes, everybody's feeling worried. And that actual worry brings us in to the type of group that we need to do the actual work. And so, when you think about it, the sicker a patient is, I went into emergency medicine because I wanted to work where I could make the biggest difference. We're now living at a moment of planetary health emergency. Is there a time in the world in history when we could have made a bigger difference? Probably not. We have the ability now to help not only everyone now alive, but to entirely change the course of health for all generations left to come. And so if we proceed with community, we make sure that people have the resources they need for their head, their heart, and their hands, we have the ability to make this transformational shift that we know will support health and well-being now and into the future.
All right, well, thank you so much, and thanks to our panelists for providing so much insight and thought, and to HGHI.
Thank you, Daniel, Samuel, Courtney, Jamila, and Mandeep for sharing your expertise with us today. I would now like to introduce our next session, Organizing Social Movements to Change Abortion Regulations. A conversation with Ana Cristina Gonzalez Félix, lecturer to the Right to Health at La Universidad de los Andes and pioneer of Cosas Justas movement, moderated by Alicia Yamin, lecturer on law and senior fellow at the Global Health and Rights at the Petrie Flow Center at the Harvard Law School. Please take it away, Alicia and Ana.
Should I just start? Hi, well, my name is Alicia Yeaman, and first of all, I want to echo others in thanking the Harvard Global Health Institute and Belinda and Louise and Carissa for all her preparatory work, which was just extraordinary. I'm thrilled to be here, and I'm also equally thrilled to be in conversation with Ana Cristina, who is an old friend, and really this is a chance to hear an inspirational story about building movements. But I also want to take the opportunity, I'm very happy that this comes early in the day because it's the only half hour on reproductive justice. And I want to emphasize that this relates to every other theme that we are going to talk about today. If you care about racial justice in health or health equity, this is at the sharp edge of that. It's not white middle-class women who are dying in this country or around the world. It's disproportionately brown and Black women and persons who gestate and people who are marginalized because of some other axis of identity, rurality, lack of education, disability, caste, etc. If you care about decolonial praxis, this is your issue, right? It is no coincidence that African activists work on reproductive justice, on if, when, and how they want to have children through that decolonial lens, or that the African Commission on Human Rights is the only regional human rights body that has really pushed this issue across the continent, again, through a decolonial lens, or that Ayanna Pressley and Senator Booker, Representative Jen Schakowsky introduced the Abortion is Healthcare Everywhere bill to overturn the Helms Amendment, saying that this was a step toward decolonizing. If you care about community-based practices, there is no better example of accompaniment and community-based practices than in this field. In Argentina, they're called Socorristas en Red, the rescue network. And if you care about even infectious disease control and trust in health systems, as Mandeep said, weaponizing health systems against a large swath of the population and turning providers into a police arm of the state is going to create mistrust and distrust. And then when pandemics break out, we see the results. And the same networks that spread misinformation about abortion worked very actively to spread misinformation about COVID vaccines. So really, in the end, if you care about evidence-based medicine, this is an issue, right? And ultimately, you know, many of us here are related in one way or another to Partners in Health. I work at Partners in Health as well as at Harvard. Paul Farmer's statement about the root of all the problems in the world is that some lives are given more significance than others. This issue is one in which the law explicitly consigns some people's lives to be less significant, for women and other persons who gestate to be less than fully human members of our society. So this is an issue that if you care about health equity and global health equity at all, it is something that we should all have on our radars. And now I'll pivot and turn to what is a really inspirational story about what the Causa Justa movement has been able to do in Colombia, which was an extraordinarily conservative country, and listen to what has been achieved, which is pretty momentous. So why don't we start, Ana Cristina, with a little bit of the socio-historical context and what has brought us to this point.
Okay, many thanks, Ali, for this introduction. I think you said a lot of very important things linked with what we've been doing in Colombia, but also in Latin America, because this is a conversation that is being very strong and in a way productive in many countries in our region, not only in Colombia, but also in Argentina, in Mexico, in many different states. We've seen changes towards the liberalization of abortion. And I also want to thank to the school for inviting me to this conversation. But as we have very little time, I try to prepare some bullets so I can stay on time. So I would like to start saying that this is being a long journey, longer than I could ever even believe. But let me start by remembering that it was 1997 when the Constitutional Court of Colombia faced a legal claim asking to eliminate the authority judges had at the time to excuse a woman or exempt the penalty when having an abortion and as a result of rape. Abortion was prohibited at that time under any circumstance in Colombia because we had one of the most restrictive regimes until 2006. But at that time, and although the court didn't change the unfair law, a gorgeous judge named Carlos Gaviria wrote a dissenting opinion. And you may be asking what this is important, is a dissenting opinion. But that was an excellent piece expressing the need to decriminalize abortion and respect women's autonomy. And it was the first light I saw in this long journey. And 25 years have passed exactly from that day where we were like clapping in a room, so happy due to that dissenting opinion. And it came from an essay without any legal effect, but with enormous hope to all of us. And 1 year after that, in 1998, we founded La Mesa por la Vida y la Salud de las Mujeres, where Causa Justa, just cause, kind of, it sounds better in Spanish, started in 2017 as an initiative that became the movement globally known for having decriminalized abortion up to 24 weeks, transforming Colombia's abortion law in the most progressive of Latin America and the Caribbean, and one of the most advanced of the world. But all this is about building power and building movements. And I'm saying this, what I'm saying with this is that one of the threats of this process is being the political accumulation we have accumulated along these 25 years. At the national level, among many other aspects, through the work of La Mesa, that before deciding to start Causa Justa, worked for almost 15 years on the implementation for the indications regime established in 2006, the first time that Colombia partially decriminalized abortion in our country. And we decided that we wanted to make that decision a reality in women's life. We did a lot of accompaniment to women. We were able to identify barriers. We were able to gather evidence, but we also produced interpretation for those indications because we knew from other experiences that that regime really didn't mean for women real access to services. And
Can I just stop? Because some people may not know or be familiar with the use of the term indications regime.
yeah,
Although
legal
that is what
grounds.
we increasingly have across this country. But maybe you could explain, or I can.
Go ahead.
So unlike the Roe v. Wade gestational age determination, indications regimes, which are very common throughout, the most common really around the world, are that abortion, there's a default of criminalization except for to protect the life of the mother, to protect the health of the mother in cases of rape or incest. So those are indications in which there is a legal claim to a right.
Exactly. And we had one of the most comprehensive indications regime because it included in cases, the possibility to have an abortion in cases or to protect women's life and health, not depending one of each other, in cases of rape and fetal malformation. So we did a lot of work to expand the interpretation of those indications or legal grounds for legal abortion. And we identify barriers as well as the need that we started to see to litigate for guaranteeing access to abortion services. So although we have this regime, we were still litigating to help women to access abortion services. And the work we deployed to train doctors at the national level also to help them to interpret each of the indications for legal abortion comprehensively. And all that allowed us to build enormous credibility, and we became nationally recognized experts in the field, but also we built relationships with authorities, with politicians, and with other movements. Not to mention that this political accumulation came too from our extensive work with colleagues in Latin America more broadly, where we imported, among others, the green scarf, and I'm so sorry I don't have mine, is in my table, I can ensure that. Or to where we exported the strategies to advance the oldest and more spread abortion regime from our region, which is exactly the indications regime. And with all these in our hands, and tired to be reacting to attacks from the anti-rights movement, I don't have to explain that here, we decided to open a public conversation in our, I like to say this, aspirational and inspirational terms, and to promote an adaptive change, creating and sustaining the public discussion we wanted to have, with the idea of positioning a critique of the use of the criminal law as a way to regulate abortion. And that's how we started this movement in 2017.
So maybe you can talk a little bit more about the movement building, since we've already introduced the need to build power and work through coalitions.
Yes, we've been doing, I can say this, most of my work has been done through networks and organizations inside the feminist movement in Latin America and in Colombia. And from La Mesa, most of our work has been also done with other organizations. So we work a lot in collaboration. And I think that the feminist movement, and I'm pretty sure about saying this, is by tradition an internationalist movement. So we've been like having encounters, meetings in Latin America the last 50 years. Every 3 years we met to strategize, to discuss. But during the first years, I told you that we started this idea of causa justa in 2017. But the first 3 years in La Mesa, we worked on developing the arguments we wanted to use for that public conversation, because we wanted to open a public conversation, and we need arguments, we need ideas to engage much more people around this, but also design the strategy that we were going to deploy, including a legal process that considered many different options for when the time came to transform the conversation into a concrete legal action that could allow us to repeal abortion crime from the penal code, changing the regulatory paradigm until that time used in most legislations around the world. Because this is not only in Latin America, this happens basically everywhere around the world. We developed 90 arguments for different audiences, And some people ask, 90 arguments? How are you gonna campaign with 90 arguments? But we wanted different type of arguments to engage different type of people. So we developed arguments from the public health perspective, from the international human rights standards, arguments around citizenship, around the peace process, around democracy, around secular state. How do we say we live in a secular state that is dominated by these kind of policies? And from the strategy, which is a very comprehensive strategy, I just wanted to emphasize here that at least three critical pillars. One is the political communications. We started our social networks. We started a lot of work with the media, traditional media, but also street mobilization, which we learned from Argentina and other countries. It's just to look at the pictures and you see what we were doing on the streets. But also we did a lot of pedagogical work. We did one-by-one or group conversations or seminars or courses with leaders, with opinion leaders, with politicians, with actresses, with ask me who, singers, public figures, even the current Minister of Justice. We have photos of him here with the scarf, and the current Vice President of Colombia. We had those kind of conversations from 2020 when we launched the movement. But the third piece, which is the most important related to her question, is that we worked since the first day. We call all the organizations from the country working in reproductive health, but also the human rights organizations and women, youth organizations, indigenous, rural, to work together. And that's how the initiative became a movement that today is composed by more than 130 networks expanded in more than 20 cities in the country that organically are part of the Causa Justa movement, plus thousands of individual politicians or opinion leaders that took the cause and started to defend it and to talk about that in many, many different places. So as I like to say, our networks are sacred. And I'm going to explain why I'm using this term that seems to be so religious. Because strengthening and building networks as well as collective work is the engine for sustainability. But when I said that our networks are sacred, I mean that they're worthy of devotion, or in other words, of the respect those deserve for what they represent and remind us, which is that together we can meet goals, we can solve problems for concrete women, we can find a space to protect ourselves, and even face the fact that abortion, as the cultural battle of this century, is something that we can fight together and something for which we need each other as a movement.
That's really incredibly inspirational. So I want to just underscore a couple of things from what Ana Cristina just said, which is one, the networks and embedding abortion struggles in broader movements, and two, the long historical iterative work that this has taken and the emphasis on social decriminalization before we talk about the legal case that they brought. And the third thing is what she mentioned in passing, which was the connection among different countries in the region, because the so-called green wave with the pañuelos verdes that began in Argentina in 2020 with legislation and then moved to Mexico and then Colombia in 2022, really is a product of a lot of connected struggles across the region among lawyers and human rights advocates, as well as physicians and providers and activists that have all worked together. And in the United States, we might take a few lessons from them. I do want to turn to the legal claim itself in that Causa Justa brought.
Yes, and I also want to emphasize very, very quickly what you said, because when we started this, I told you that we worked during 3 years, like for among us, developing the arguments, the strategy, but we launched the movement in February 2020. And that's when we started to do all this pedagogical work with so many people. And after 2 years after, we measured with what happened with the digital conversation around abortion. And we saw that our terms, our arguments dominated, and I don't like to use that word because it sounds like terrible, dominated in the sense of statistics, all the conversations. So we changed a conversation that used to be, we need someone against, and someone in favor, and that's how we are going to talk. But because people really wanted to understand what we were saying, what is this? Do we have a crime? Oh, we didn't know we had a crime. And many people started to ask those kind of questions, and including some very conservative people started to say, well, but we already have the indications. Previously, they were against the indications regime, but then when they saw we were growing, they said, we already have this is so good, this is very important. And people move from the indications to the idea of repeal abortion crime from the penal code, which was our legal claim. So as I've mentioned, it was essential to design a strategy, but to be flexible. And very soon after we opened the public conversation in February, as I told you, we saw a window of opportunity in the Constitutional Court. Then I can explain you what was the window. And we decided to file a claim asking the court a very simple thing, to eliminate the abortion crime from the penal code, leaving to the health authorities the mandate to regulate outside the criminal law. So we developed 5 or 6 main legal arguments based on those 90 arguments, on the idea that the crime operated as the structural barrier that women faced when they tried to access abortion services, and that the use of the criminal law should be the last resource to regulate a health service, as there were other ways to protect women's rights and also gestational life. And due to that significant barrier, women's rights to health, equality, and freedom of conscience were being violated. And we also developed in that legal claim that the same thing was happening with the right to exercise the freedom on the medical profession or the secularity of the state. And it took the court 523 days to make a decision. During those days, we were doing that pedagogical work that I explained. We were doing social media, and we were in basically all the media in our country, but also internationally, as you can see in the pictures. We didn't stop 1 second, because this is the only way to continue building power while you are doing something that is pretty much technical inside the court. You need to mobilize and keep the conversation going on. We also promoted expert testimonies or amicus from national and international experts like Alicia. She also gave an extraordinary amicus, but we got more than 114 amicus curiae from international and national experts, former ministers. Nothing of that happened by chance. We did all the work behind that kind of things. And we always kept, and this is so important for me, our final goal in mind, no matter how much we got pressured or faced uncertainty. Because at some point, 500 days, people started to ask, shouldn't you say to the court that they might maybe just give you 14 weeks of pregnancy and establish a time limits regime and that's it? And we said, no, we are here talking about a change in the paradigm. Let's see the court, they are gonna do that maybe, and they did it. And that's how Causa Justa legal claim ended in a landmark decision, which is have a number, CO55 from 2020, by the Constitutional Court of Colombia, that established that abortion shouldn't be a crime when performed before 20 weeks of pregnancy, and that in all cases after that time limit passes, the crime won't be applied to the 3 exceptions to the crime that already existed from 2006. Additionally, the court urged Congress and the national government, without prejudice to the immediate effect of that decision, to formulate a public policy. So That's how it happened. And the decision of the court, there were other legal, more complicated arguments, you know what I'm talking about. But the court at the end says they recognize that due to the crime of abortion, women's rights to health, equality, and freedom of conscience were violated. And it was so important because now this decision is like rooted in very fundamental principles of our Constitution.
So it is an extraordinary judgment and an extraordinary paradigm change and achievement. But it was a 5-4 judgment. And interestingly, for feminists, only one of the female justices voted in the majority. And now, you know, it does face extraordinary challenges in terms of implementation and the design of public policies. It wasn't accidental that you went to the court instead of to Congress initially. So maybe you can talk about, you know, the judgment as an inflection point, but not as the end point of this struggle.
Last year in February 2020, after the court released the decision that we call causa justa decision, many people asked me if that had been the most important day of my life, as we had accomplished something incredible and were ready to rest. I did laugh. Conquering a right so contested in our societies is just the beginning of new challenges. And remember that once you reach your goal, a new job starts. Even my partner asked, so you're now free? And I was, no, I'm not free anymore. So after the judgment, we have many challenges, but we have like grouped those challenges around 3 fronts of work. The first one is the implementation of the judicial decision. We need that decision to become something that make a difference in women's life. For that, we need to work with the health system. We have a strong health system, although many people don't consider it's strong, but most of our population is insured. And we need to ensure that those women get services through our health system. But if they don't want, we also need to ensure that they can have a self-managed abortion. So we need to work a lot in training doctors, in changing the way in which implementation has been done. And we have some data that showed us that after 1 year of that decision, because we in La Mesa accompany women that face barriers when trying to access services, that the need of litigations fall 30%, which is a lot. So now our health institutions are providing services much more than 1 year before.
So let me just explain that. In Colombia, in the legal system, there is a writ mechanism where an individual can bring a claim to court that has to be resolved within 10 days. So it's not the way our legal system here works and challenging abortion restrictions.
Yeah, but it was that resource and many other, legal resources that we had to use in order to make those institutions to provide services. So implementation is in the core of our work, but the second one we have called the protection of the decision. And I don't have to explain you that we've learned from Roe versus Wade in the US that a judicial decision is legally and politically vulnerable. So we've been doing a lot of work on that. Yes, I'm pretty aware of the 5. We also have to, now, for example, we are facing 17 nullity requests to the court to annulate the decision and many other things. Every time that something happened, the anti-rights, they sued that decision. So that's how it works. And the last one, which is the social decriminalization, the most important for us, because it means making the judicial decision sustainable through social and cultural changes. And to get into it, it is necessary to continue talking about abortion publicly and being responsive to every conversation to that, so that one day people's hearts and minds will change profoundly. Everyone must learn that this is a peaceful decision, and I love to say this because it allows every woman to be or not to be a mother based on the reasons and departing from their moral integrity and the recognitions that women are, full moral subjects. Ultimately, all this is about building legitimacy on women's decisions and making the change sustainable in time. In many ways, we changed one of the most challenging conversations of our time and did it in our terms. After 1 year, we continue being part of the headlines highlighting words as freedom, historical year, 1 year of more autonomy for women. It didn't happen. I can assure you that in our media. And that happened in Colombian leading journals, podcasts, TV, radio programs. But nothing, and I'm gonna end with this, nothing of this would be possible without the movement and the power we build, without causa justa fighting every time and every second needed. Society today knows that a crime like abortion is unfair, is inefficient, is counterproductive, is discriminatory, and I would add, obsolete. And society also knows that without that crime, we can celebrate women's freedom, lives, health, and dignity, that women can choose how to live and pursue the life they dream for them. And in such a way, we will become a much better society, a society that one day will ask itself why that crime ever existed. And we will just wholly and definitely delete it from our penal code.
Thank you so much, Ana Cristina. So reflecting from the United States, I think I hope that we can follow the inspiration of Causa Justa and the other countries of the Maria Verde, Argentina, and Mexico. This is a democracy question as well as all of the others that we've raised. Who gets to have power over who and of what kind, and who gets to decide whose life plans mean something and whose don't. So I hope you continue to think about this throughout the course of the day and much longer, and take advantage of having a really inspirational leader here to talk to and learn from the experience in Colombia.
Let me add something very little. I know what I'm gonna say sounds controversial, but the earth spins around, and maybe this is time to look to the global south and learn from our experiences, strategies, and arguments. And I say this with humble. So thank you so much. I like microphones.
You took the mic with you. Well, thank you, Alicia and Ana Cristina, for this very important conversation. We will now be taking a short break. Behind me, you'll find light snacks and refreshments. And we'll be back, and we'll ask you to be back promptly at 11:30. Yes.
Take your seats once again for the next session. Thank you.
Welcome back, everyone. Please allow me to introduce our next session, Challenging the Status Quo for Our Sustainable Future, Promoting Health, Equity, and Resilience. A conversation with Winnie Beniyama, Executive Director of UNAIDS, and moderated by Vanessa Carey, founder and CEO of Seed Global Health, and Director of the Program in Global Security and Social Change at Harvard Medical School. Vanessa and Winnie, please take it away.
Hi, Winnie. It's good to see you. I'm sorry that I don't get to see you in person. Can you hear me okay?
Yes, hi Vanessa. It's
I
lovely
can't hear
to
you
see
though. Are you by any chance on mute?
No, I'm not on mute, but I'll sort it out. Give me a minute.
No, I hear you now. You are good. So I'm glad we're connected, and I'm going to take a quick moment just to introduce our session, if that's all right. You probably, I don't know if you can see me or not, but I'm happy to see you.
I can see you.
Okay. Good morning, everyone. Good afternoon, good evening, depending where you are in this world. I'm really excited about this session, primarily because of who we're having a conversation with and because of her extraordinary championship of many, many issues, conversations, actions, justice, things that we need in this world today more than ever. Because I think it goes without saying, this is probably the understatement of the century, but we are really coming out of the worst shock that we've seen since at least the Second World War, if not in some ways, given the range of globalization, our size of our connectivity that we've seen in modern history. There are millions dead, and there are many more that are suffering the trauma of the last 3 years every day. And that's not just the trauma of having gotten sick, but that's about falling below the poverty line further. It is about the inequality we have seen for women as they fall back and we've lost the gains that we've seen. It is about the people who are more vulnerable, the rise of migration. It is about all the ways that we have seen the impacts from this pandemic and the way people have behaved and the power structures that we've seen. And so it's absolutely appropriate, it is right, and it is necessary that the global community is reflecting on what we could or should have done better, but frankly, what we need to do from this moment forth. And in particular, we know that the pandemic really threw into sharp relief the startling inequalities extant in global health and in how our world works today. Issues of equity, gender, race, sustainability, power, and inclusion are all key to unlocking the progress that we want to make on health and well-being. And none of it happens without people, without partnerships, and we're at a tipping point. We are truly at a tipping point today, and we have to take bold action to change the way of doing, or the old way of doing things. I can think of no one better to lead us in this conversation and to help guide us in this moment and to wrestle with us in this unknown than Winnie Beniyama. She is a passionate and longstanding champion of social justice and gender equality. She's the executive director of UNAIDS and an undersecretary of the United Nations. She leads the United Nations efforts to end the AIDS epidemic by 2030. She believes, thank God, that healthcare is a human right and has been an early champion of the people's vaccine against the coronavirus so that it is available and free of charge to everyone around the world. And that's where I first really had the privilege to connect with Winnie and to work alongside her. As a global leader on inequality, she's co-chaired outside of the health sector as well, which I think is important within the World Economic Forum. She served on the World Bank's Advisory Council on Gender and Development, the International Labor Organization's Global Commission on the Future of Work, and the Global Commission on Adaptation, bringing the critical importance of health into all of these other sectors because health is fundamental to everything that we do. And I think what I love, one of my facts I love about Winnie is that she's also the first female aeronautical engineer from Uganda, which is not an easy feat on any level. And she holds what I think is one of the most important titles, and one that I'm honored to share with her, which is that she is a mother. So I guess I'd like to just start with something that is really close to my heart, slightly self-serving, if it is okay, but health workers. Because as we emerged from a global pandemic, the same nurses, physicians, community health workers, and health workers of all different cadres who were heralded as heroes, had pots banged for them, were clapped for amid all the shutdowns, are today continuing to show up in systems that too often aren't equipped, aren't staffed, aren't structured to adequately serve the community's needs and those that are most vulnerable. And we need to invest in our health workforce, especially women in their leadership, where women are 70% of the healthcare workforce, 90% of the patient-facing workforce positions, but only 25% of the leadership positions. And so how do we turn the tide and invest in our most critical resource, which are people, when it is not the trendy investment or really one that is fully understood to make?
Thank you, Vanessa. But you're frozen.
Am I? You're not frozen, so keep talking.
Okay. I thought you were still talking. But thank you so much for inviting me to this conversation. And Vanessa, I admire your global championship, being a global champion for health workers, and particularly women health workers, who are the majority of health workers. Look, I will start with a woman I met and who stays on my mind. She's called Juliana. She's a community health worker in an informal settlement called East Lee in Nairobi. Juliana is in her early 20s. She's living with HIV. She's a survivor of sexual violence. She managed to get on treatment. She's alive and well and has two sons who are HIV negative. So she was able to benefit from the science. And now she's a community health worker. She links women, usually very young women, many times teenagers, to the health center in her community. She counsels them when they are found HIV positive on how to stay on treatment and have healthy babies that are HIV negative. For all this work she does, being the link between her community and the health center and saving the lives of many babies and mothers, she gets paid $20 a month. That is the stipend she's given as a volunteer. She's considered a volunteer, community volunteer. This is the face of community health workers that I know, that the majority of community health workers in the world today are either unpaid or underpaid. Their work is not valued as it should. It's even invisible, yet it is life-saving. They face the risks of being on the front lines, and they're just not counted in the global health system. This is also true about the rest of caring work, healthcare work that happens in the family, in the community, that it is done by women, by moms, by sisters, by even grandmothers. And this unpaid care work contributes to the global economy trillions of dollars. But that too is not counted in the global economy as work. So you find where women work in the care sector, caring either in the formal health system itself or in the informal setting of family and community, that their work is not recognized, is not valued, is as it should, and is not remunerated. This is a global problem. And it stems from the other point you made about leadership. If the leadership in global health is dominated by men, like you just said, 25%, how can we ever expect that the contributions of women to global health will ever be valued and made and remunerated fairly. Of course, it won't happen. So the question of leadership in global health, in healthcare, is so important. And getting women to lead there is not rocket science, because they already are there. They are there because they have been trained, first of all, socially to care through their socialization. They are trained because they go into the care sector and get trained as nurses, as doctors, so they can also be leaders. They're just excluded because of the patriarchy, and we need to open the space for them. It's political will, it's not rocket science. So pushing and pushing for the leadership of women in healthcare is critical, because it's not only about a human right to themselves, but it is about how the whole healthcare system is seen and valued. Who would not say that the work of Juliana is life-saving? How can it be called how can it be treated as just voluntary? Until we have the leadership of women, we will not, in key positions of in the global health space, from global to national to community to local government, we will not solve this problem of structuring health services to meet the needs of all people, men and women and children, and others who are non-binary. So leadership. Should I pause there? Because I talk too much, Vanessa?
No, you don't talk too much. I'm sitting here though. I mean, I have many questions I'm ready to still ask you too, because I think that as you're articulating some of the problem, right? And you're articulating the need to make this transition, and you're talking about poor leadership. And I would argue we have a pandemic of bad leadership in the world today. The question then that I would like to ask you too is though, what are the levers that get pulled to change that dynamic, right? How do we take this problem, the recognition you said, 3 trillion of our global, economic input is from women, women in the health workforce add 3 trillion to our global economy, but only half of that goes paid. What are the levers though that we have to pull to actually truly see that actionably change? Because I think that's the question, I'd love to hear you elaborate on too, because you've deep experience in being an activist and being a policy or an advocate for policy change and helping to see those policies change. And your leadership in the People's Vaccine was profoundly needed to at least gilt some of the shifts that did finally happen. And we're not there yet, and I will ask you about that in a moment. But tell us a little bit about where you see the opportunity for everybody listening here today to go forth and help to create that action.
Vanessa, on this question of what we value and what we want to invest in because we value the health of our people, the education of our children, and all of that, we need to go back to the definitions of what is economic progress, socioeconomic progress. There is a project going on now at the United Nations on measuring the global economy beyond GDP, to look at what are we measuring. We can't just measure growth of economies and count that as socioeconomic progress. We must value more and have a better measurement of whether we are progressing. Lives are being saved, people have health, kids have education, people have housing. These things need to be part of a global measure of economic progress, socioeconomic progress. In this project, it's so important that we build in there the work that feminists have done for many, many years of proposing how to value the unpaid care work that women do. Because our weakness, women's weakness in decision-making, whether public or private sector decision-making, our weakness in the global economy where we earn, generally there's a huge wage gap globally, the fact that men own more wealth than women globally, all these things actually stem from our subsidy we give to the global economy by doing so much unpaid work, caring work, which we love. We love to care for our kids, for our husbands, for our communities, but by not counting it as important for the economy, that these people we care for are the labor force that produces the goods and services, by not counting that, we are cheated. So reviewing the way we measure the economy, we measure progress is important, and that's a project that's going on, has been going on, but we need to bring in that feminist perspective of how to value what women do, because we don't only go out there to teach and to build roads like men, but we also care, and care has value too. So that is part of the solution we need. But beyond that, we also need to get to do what you do, that challenge our governments about how they remunerate people in the formal system. Care services cannot be valued as less important as putting up a building, that a construction worker can earn more than a nurse, than a child carer in a creche. Why we need to see that the work that women invest in is valued as well as the work that men do. We see silos in labor because women tend to be in care areas, but they are underpaid.
Yeah.
And men go into some sectors that are more infrastructure related and so on and get better pay. That can't be right.
So here's another fun one for you that is not right. The COVID-19 pandemic highlighted the challenge of local production. I'm very excited for your answer on this. And especially on local production capabilities in Africa, where the continent is still currently importing 95% of its essential medicines and more than 80% of its medical supplies and equipment. For example, PPE, which is needed for innumerable number of diseases. This is absolutely unsustainable from a cost standpoint and efficiency standpoint, and without question unacceptable from a health equity standpoint. So to improve health outcomes, to be better prepared for the next pandemic, but I would argue also to embrace that value system that you're talking about, that well-being agenda that is being championed at the UN and I think really is going to be the crux to sort of unlocking a lot of the answers that we need. We know that Africa needs to boost its production capabilities. What realities, though, do we have to confront when making the case for investing in Africa's pharmaceutical and medical supplies production sector? What are the pragmatic and courageous solutions that we need to take forth? And what are the power structures that we are really struggling against that are deeply entrenched and historical?
Vanessa, that's really a very important question of today, and it's urgent. I'm sitting here in Washington, D.C., by the way, and I'm here for the IFI spring meetings. Mm-hmm. These institutions are key here, but they are not the only ones that are key. We saw during COVID, we learned some sad lessons. One, that you can have a life-saving vaccine, but that millions can keep dying and without access to it. And all because the rules allow it. The rules allow companies to monopolize a technology, set the price where they want, sell it whoever they want, and take as much profit as they want at the cost of lives. The lesson there for some regions, particularly Africa, that were excluded from accessing that life-saving vaccine was that we must build capacity in every region to produce the technologies that are needed at any time. And that capacity in Africa was very, very low. the African leaders came together and said, never again. We are setting a target. By 2040, we must produce 60% of our own health technologies. They've set such a target. But setting a target is one thing, reaching there is another. You are right to ask the question, what will it take? And that question is not just for Africa, it's for the whole world, because we saw how the virus respects no borders, was spreading across, and every country was affected. And unless we could lift everybody out, it wasn't going to end. But even now, I see that in this great country, the President Biden has signed off the end of this pandemic. That is great. But at the end, 3 years on, you still have like 20-something% people vaccinated in some countries in Africa and Asia. And here it's more than 70%. So we're safe, but we're not really safe because of that inequity. So here's a local production agenda. We're seeing some positive things. We're seeing WHO coming together with some governments to support South Africa to establish an mRNA platform. By the way, South Africa was able to come up with a vaccine like Moderna's on its own, with no support from Moderna or anybody, within a year of Moderna's innovation. So it's not like there's zero capacity, there's capacity, but there's a lot to build. So there's a hub created in South Africa. I visited it. It's led by an amazing woman, and it is setting up to produce many, many vaccines, treatments, diagnostics using that mRNA technology. But that is at the lab level. To take it to manufacturing, to marketing and distribution all over will take so much more. It will take international institutions such as Gavi, Global Fund, even the big countries, programs such as PEPFAR, to agree to procure from new companies that are now growing on the continent, that are taking technology developed in Africa to develop African products, to buy from them so that they grow. So it will take international solidarity. It will take the Modernas of this world and the Pfizers to share their knowledge as well, so that this platform moves fast to make breakthroughs. It will take South-South collaboration, because it's true, there are southern countries with strong production capacity. India is the pharmacy of the world. Brazil is there. China is there. These countries can partner with a continent like Africa, where production is done, but innovation comes from Africa. You make an African product, you produce it in an Asian factory, you bring it back and distribute it. These are solutions to the production problem, but we must not get to the next pandemic, and it's not an if, it's when. The next pandemic must not hit us when, and we come back to this situation of no gloves, no oxygen, no incubators, no, in some regions, and some regions have and others don't. So these things must start to happen, and it's going to take market integration, technology transfer, capacity of people, young people in the science, in innovation, and these things can happen. And they are beginning to happen, Vanessa. And your country, the American government, is key here, because you are the biggest contributor in global health, in supporting other countries to build their capacity, and that leadership must stay. But we need the whole world coming in together to balance capacity in all regions. Then we'll be prepared as a world. We'll be prepared.
Thank you for that perspective. I think you you've been an extraordinary champion over the last 3 years to really tackle governments, corporations, and others to think about how this can be done differently. And certainly, without question, when I think about the work that you're doing and the goal to end the AIDS epidemic, in just a few short years, the ability for local production will build that kind of efficiency and access. I want to take a moment because I am hogging you, so I want the opportunity for the audience to maybe ask some questions, and I have some questions from online as well that I would like to ask you. Are there any questions in the room before I turn to the online audience at all? While I wait for some hands to go up. I have a question. This is another one that's near and dear to my heart, so I'm going to keep taking the prerogative of the lectern to ask you some of these. This is from Claire Birabawa from Uganda for you. How can health equity be achieved in the context of climate change?
Hey, that's a really tough one, because the climate impacts that we are seeing today, first of all, are mostly in the developing countries, are harshest in the developing countries. We are seeing, for example, in Africa, the floods that are washing away people's homes and killing people, the droughts that follow the floods, and then the floods that follow the droughts. It's almost like extreme weather is hitting many countries and washing away their hard efforts at development. New roads are washed away, bridges are washed away, and all this from scarce resources that are borrowed. So, but in terms of the health impacts, we are even yet to know what is coming, because like I said, these extreme weather conditions are producing climate refugees, are increasing certain diseases that we thought we had begun to control, forms of malaria, chest infections. We're seeing, and we are still to know the disease burden that is emerging from these adverse weather events that are almost cyclic now. In some countries, it's all the time. So we need to have resilient health systems that are mostly working on prevention, giving people good health, because we know that if your starting point is that of being very healthy, strong and healthy, that you will survive adverse climate, or whatever climate shocks come, you survive better, or even economic shocks, all kinds of shocks, you survive better if you have strong immunity and you have had prevention. So turning our health systems towards prevention of disease, in good nutrition, overcoming hunger. Hunger has started to rise again as a result of the multi-crisis. It was declining in the last 10 years. Now it's rising again. So overcoming hunger, nutrition, these are the things that will enable people to survive climate impacts. So your question in short is that we don't know yet how our health is going to be impacted by climate change. We are beginning to see it. And our response must be to invest strongly in health systems and make those health systems reach everyone, inclusive health systems. And because we know with pandemics, they start at your weakest point. Those who are not reached are the ones who succumb. And that is where the pandemics tend to spread from. So until we have health systems that reach everybody, serve people equally, are inclusive, we will not be able to survive and endure the climate impacts.
I think that the approach of the resilient health systems and the ability to respond to the climate emergency, but also meet our burdens of disease and invest in healthy populations. There's a win-win-win across this that I think brings up a lot of what you touched on, which is that there's really a multi-sectoral approach that is based in the values that we bring forth and the values that have to shift for this moment in time. And I think that is what all of our work is going to be, is to begin those conversations, to seed them, to nurture them, and to push for them also through, it's very interesting listening to the planetary health panel earlier, and they're really talking about what it means to create movements. And I think creating movements we're all capable of that, and we're all responsible to that. And I think that happens on every level, from local up to what we push on a global level as well, in that cascade. We have about 1 minute left. And so I would love for you to just close us out with some either words of wisdom, call to action, final reflections.
Well, I always have to go back to the human rights approach, that we must continue to use a human rights framing in pursuing global health, that health is a human right is the starting point. And that means building healthcare systems that equalize, that give everybody that opportunity, but also that health is seen as, yes, a human right, but seen as and approached in a multi-sectoral way, that our health is not about the health system and going to seek health, but is about us eating well, getting educated and being aware of our health. It's about ending that silent pandemic of violence against women and girls. So it is a multi-sectoral approach that guarantees the right to health. It starts with human rights. I think that is it, and that we must make this a global public good, that we must accept that the right to health is a right for everyone on this planet, and therefore we must build a new way of delivering these global public goods, whether it's health, education, the environment, ending, stopping the climate crisis, that all of this must be funded publicly by all of us, that every country contributes, every country takes out of the global funds what it needs to solve its problems. That if we take such a global public goods approach, then we can be safe on this planet. No one is safe unless everyone is safe, should be the mantra. We say leave no one behind, but I think we should talk about no one is safe until everyone is safe. This is my last point, that let us use a human rights framing. Let us look at human rights as us as investing in them for everybody, and all of us getting out what we need. That's it, Vanessa. And I thank you so much for the opportunity.
Thank you, Winnie. And we look forward to walking together with you to create this change. And so thank you for your time, and kindly go change all those institutions' minds.
Thank you, Vanessa. I enjoy working with you.
I love it too. More to do. Be well. Okay, you're all set.
Thank you, Winnie and Vanessa, for providing your expertise. I would now like to introduce our next plenary session entitled Advancing Equitable Partnerships in Global Health, Building Upon a Decades-Long HIV Response. We're fortunate to have a tremendous group of speakers joining us today. Giving opening remarks is Phyllis Kanke, Professor of Immunology and Infectious Diseases at the Harvard T.H. Chan School of Public Health. Professor Kanke, please take it away.
Thank you. It's a pleasure to be here and to introduce our lovely panel. It's a great topic because I think as those of us at Harvard here, it's an academic institution, and we want to learn from the lessons of the HIV response. So I'd just like to make a few comments. About 30 or 40 years ago, when I was a graduate student in virology, I went to Senegal for the first time, my first trip to Africa with Max Essex, and I met an assistant professor of virology, Dr. Suleiman Boop. And we, at that first meeting, we signed an inter-university agreement that would dictate how we would do research on HIV for the long-term future. And I'm very proud that we actually held to that agreement, and we trained lots of Senegalese physicians and healthcare workers and laboratory scientists, and we conducted very productive research on HIV-2, which was the West African virus. And so I think that became an important model for co-equal partnership, which I think is very important if we think about the importance of research for all health problems in the future to come. And the other point I wanted to make was about PEPFAR. I was fortunate enough to direct the first PEPFAR program here at Harvard. It was a 3-country program in Tanzania, Botswana, and Nigeria. And as many of you know, this is the 20th year anniversary. It was a unique and really groundbreaking program, saving 25 million lives and more to come. But I think importantly was really founded on the principle of country ownership. And although at the very beginning in 2004, they were still sort of figuring out how all of that would work. I think over the years, they've gotten that to be better. They've understood the importance of community involvement all the way down to the grassroots, and they've understood what co-equal engagement means for sustainability. So I hope we can think about those lessons as we move forward. So I have the pleasure of introducing our panel today. Professor Linda Gale Becker is a professor of medicine at the Desmond Tutu HIV Center and at the University of Cape Town, and she's the CEO of the Desmond Tutu Health Foundation. So thank you for joining us. We have Maureen Luba, who I've known for many, many years. She's a program manager in Malawi at Cooper Smith, and I understand is a degree candidate again back here at Harvard. Dr. Mozapeli, who's from the University of Botswana. I've also had the pleasure of working at least alongside many of our colleagues from Botswana, and we're very happy he made the long trip to come here. And then my dear friend and colleague, Dr. Shaheen Lockman, who's an associate professor both at my school, at the School of Public Health, but also at the Brigham, and who has been involved with the Botswana-Harvard partnership since its beginning. So thank you very much.
Thank you all for being here today in person and online, and thank you so much for convening this particular panel, which we're very excited about. So I think it's known to all that over the past 3 decades, the global community has collaborated on a massive expansion of HIV diagnosis, care, treatment, and prevention programs, scientific and research capacity, and investigation, and community engagement around HIV. Much clearly remains to be done. We are not finished with that work, and not all communities, not all people have benefited equally from the investments made. Nevertheless, it is fair to say that we have succeeded in many ways. 3/4 of people living with HIV now are estimated to be on potent treatment for HIV. The rate of HIV and AIDS-related deaths has dropped by more than 70% since the peak of AIDS-related deaths, and new HIV infections have also been reduced by more than half since 1996. So our panelists here in person and online, each in their own particular areas of expertise, have a total of more than 50 years of experience tackling HIV. Just think about that, 50 years. And so really, I think today we want to ask these esteemed individuals with their cumulative wisdom and experience to reflect on what we've learned from this decades-long local, regional, and global partnerships that were established to combat HIV. I think we'd like to hear about partnerships that have successfully included affected communities over time, and what impact community involvement has had on equitable HIV care. And perhaps at least as importantly, hopefully we can have some candid conversation and remarks about instances in which that didn't happen and the downsides of lack of community engagement. I'm hoping we can also explore how these HIV-focused partnerships may already be addressing other public health issues, and looking forward, reflect on the guiding principles, particularly equity and community engagement, that our partnerships need to follow as we tackle ongoing and future health challenges. I think we're going to have a round of questions going really from Maureen to Mosapele to Linda Gale, initially talking a little bit about community and partnerships, and then really folding in equity. These are obviously overlapping and interwoven, but for each of you, I'm also hoping that you will be able to address the particular, when you think about and engage community and think about partnerships, what those specific communities and partnerships are, because you each bring very different perspectives, again, overlapping, but quite different. So first, I'm also hoping that each of you can maybe tell us why and how did you get here today? A little bit about your journey on your path, Maureen, starting with you, your journey to advocacy and activism, and how you were and why you're here today.
Thank you so much, Shaheen. So I wear so many hats, but I think one of the hats that I hold so dear to my heart is that of being a community representative. I think I would say, if I may, of course, borrow from a leaf from Winnie, I would like to share a personal story, because my journey, my advocacy journey has been quite emotional. I remember back in 2013, fresh from college, I was excited about life. I was excited about, advancing my career. And my first job was with, back in Malawi then, I was with National Association for People Living with HIV. So I used to spend most of my time, working in the communities, working with people living with HIV, most of them vulnerable, poor, women, and all that. And it was, I still remember it was in December, one early morning, I was just out in the field doing my routine meetings, but with this time around, I was meeting a support group of people women living with HIV. It was a small group, and I noticed that among the group was this woman who looked older. My guess was she was maybe late 60s, 70s, early 70s. But I had so many questions, because by then I was still, young, so naive about HIV. I was still learning a lot about HIV. So I had so many questions. How come she's part of the group? How did she get infected? Because my understanding was that HIV was only for sexually active, young, sexually active people. So I had so many questions. questions, but I noticed something else during the course of the meeting, that she was shivering, she was shaking throughout the meeting, and I was quite disturbed. So immediately after the meeting, I reached out to her. I wanted to understand how she was doing, and that's when she told me, I asked her why she was, shaking throughout the meeting. That's when she told me the reason why she was shaking, it was the effect of the medication that, she took. Every time she took the medication on an empty stomach, it would actually make her shiver. That's when I realized that she had taken her medication and she didn't eat anything. So I also noticed that her clothes were soiled, and when I asked her where she was coming, she told me she was coming from a garden. So apparently she had borrowed a small basin of maize from one of her neighbors, and in return, she was asked to dig in the garden about 1 acre. I felt so sad. I wanted to learn more about her story, so we offered a lift, back home. We offered her a lift back home, and that's when she told me how she got infected. Apparently, her husband back then, he used to work as a night watchman in a nearby township. He used to sleep around with women. She knew about this. Every time she would confront him, he would threaten to kick her out. She had nowhere to go, so she had to stay in the marriage. Apparently she got infected. But she also taught me something else, that also disturbed me. She was like, every month she had to travel a distance of 10 kilometers on foot to get her medication. And I asked myself, can a woman like her even have a chance to meet, policymakers, funders, and decision makers to just share her problem for them to understand what she really needs? So that's when I made a commitment that I'll do what I can. I'll use, the platform, my voice, any platform, to raise the voice of communities, to raise the voice of women like her. So it's been tough. It's challenging. There are times when you're frustrated, you think you're not making headways, but every time I feel like giving up, a voice keeps telling me, Maureen, you're not giving up. You're not letting those women down. So that's how I've kind of found myself here.
Thank you so much. And that story, that one story, so beautifully illustrates the many impediments and challenges that individuals living with HIV face every single day. And so I think you've worked in many capacities in advocacy and activism, too numerous to expound on in detail, but can you give an example or two of particular instances or experiences during that advocacy and activism in which you could see the effective inclusion of community voices and how that improved outcomes, or conversely, how the lack of that inclusion and true inclusiveness led to poor outcomes?
Yeah, I think I just wanted, to start by emphasizing that when we talk about community engagement, it has to be at all levels. I think it's great to see that now there's great recognition for community leadership, community participation, community engagement. But sometimes we tend to pick and choose, right? Sometimes we say we only want to engage community. Okay, now there's, this whole idea of, for example, putting together community advisory boards, right? Which is great, but there are times when you pick to choose and say, oh, we can't involve communities at this level. This is too technical for them to understand. No, make them understand, because at that moment when we start to pick and choose, that's where we start making, mistakes, right? That's when we start leaving communities out. I think I would say there are a lot of examples, in which community have been, participation has been vibrant and effective. And I think one that quickly comes to mind for me, I always think about, the DDG transition. Mm-hmm. If you remember back in 2018, preliminary results from an independent study that was conducted in Botswana then had identified a potential safety issue with DDG. Actually, 4 out of 426 women who got pregnant were also on DDG. Had tube defects. I remember that caused a great deal of panic, because by then DDG, was being considered as a game changer for people with HIV because of its, great tolerance, high potency, but also a high resistance barrier. And countries had to make decisions, right? So there was a great deal of panic among communities, but also among, policymakers, Minister of Health. I remember that's when I saw how communities, especially women living with HIV, were involved, right, in the conversation. There were a lot of consultations that were organized by WHO. I remember women were involved, not just at country level, but also at the regional level, but also at the global level in making those decisions. Because I think at that time, WHO realized that it was really important, to make sure that communication was very transparent and also consistent. Because by then we had already started hearing myths, to say, oh, ARVs will make you, infertile, things like those. So you had to make sure that communities had access to information. They were being represented at different forums and distilling that same information to communities on the ground, so that, the demand for ARVs, the demand for access to medication was still there. So I think for me, that's like a great example. And because of that great community engagement, we are able to resolve that issue. And I think another one, which is more recently, which I think is quite inspiring, is how I've seen this issue of community-led monitoring. You hear a lot about it in the HIV space. It's becoming a thing now, whereby communities are being empowered, right, to take leadership in monitoring how services are being delivered, the quality of the services. So what they do, thanks to Global Fund and PERFA, by the way, they're providing support to communities so that they can do this community-led monitoring. So communities go into the facilities, they go into the communities, they talk to recipients of care, they talk to healthcare workers, and then try to understand where are the challenges, where are we missing it, and then they use those findings now to engage policymakers, healthcare workers, donors, to say this is how we're supposed to address the existing challenges. So it's a great example in which communities are actively involved, yes, in identifying the challenges, but also providing solutions and being engaged at different levels where decisions are being made. I don't know if I still have time, but I mean another great example that I would like to share is a project that is being implemented in Malawi. It's called Blantyre Prevention Strategy. It's also a great example when you think about bringing all hands on deck. So how Blantyre Prevention Strategy works is that it has brought together, the goal is to reduce new HIV infections in Blantyre, but it has actually brought together communities, healthcare workers, district planners, policymakers to identify. So there's a platform called PAMS that draws data sets from, that uses information from different data sets to draw some insights in terms of what's happening with HIV prevention in Blantyre. Where are we seeing new HIV infections? So communities, how they are involved is they are involved in the production of that knowledge, but also they are the users of that information. So those are some of the examples that I can say I've seen great, partnerships where communities have been fully involved. Of course, there are also the bad ones where, we haven't seen that great deal of community participation. The results are pretty bad.
Thank you so much. Those are remarkable examples. And I can say, reflecting from the perspective of just the global perspective, each of those examples I am aware has informed policy, has it intersects also the first one with reproductive health. So the results are tangible when done, when true engagement happens and people are empowered. Thank you so much, Maureen. So now I'm just going to turn now to you, Mosapele. And would you mind also describing your journey? What led to you being here today, and why? Why did you choose this journey? And how has it led to some unexpected twists and turns, particularly during COVID?
Thank you very much, Shaheen, and good afternoon, everyone in Boston and those who are far away. Good morning, good evening. Depending on where you are. I have been very, very fortunate, Shaheen, in that I grew up in a country that's very peaceful, and education was free. Never had to pay a dime for my education. And therefore, also where there is immense potential for growth and opportunities. Country the size of Texas with 2.3 million people. Imagine what if you were maybe one of the first infectious disease doctors, what you could do. So I've been very fortunate to get to that. And whilst I was settling in to develop a career in infectious diseases in Botswana, COVID-19 happened. I never saw that coming my way. Was very fortunate when that happened. Literally, I had flown to the US for CROI. I spent a weekend in a hotel here in Boston and had to fly back because CROI was not happening. And on the Monday when I landed, we were summoned to an office and told we have to form a COVID task force. And I was like, oh Lord, okay. I thought I was still remain in the medical school and just give advice, but I found myself deputizing the presidential COVID-19 task force and chief negotiator for the COVID-19 vaccine. So it was an interesting experience.
Thank you. And interesting is one word for it. I'm sure it's incredibly grueling and challenging, but highly impactful. I think maybe could you describe a little bit the partnerships that you had to engage? I guess now, since we're given the topic that we have at hand, the existing expertise, infrastructure, and longstanding partnerships in Botswana that had been established to respond to HIV, how you engaged these partners to swiftly respond to COVID. And I think, as you maybe reflect on this, in what ways these partnerships really served the country, whether they, particularly the global partnerships, but also the within country and regional partnerships, and how they didn't maybe serve the country, and how we can make them more useful and equitable in the future.
Thank you very much, Shaheen. I'll take it back before HIV. Botswana is largely a farming community. Almost every family has cattle or goats. So we have learned a lot about disease outbreaks from when we had foot and mouth outbreaks, and they still happen because we have lots of wild animals that intermittently mix with our own cattle. And then I remember as a child also when we had contagious bovine pleuropneumonia outbreak, CBPP. And so historically, the country is divided into zones for animal disease management. Historically, we have used veterinarians to help us manage both human and animal disease. So interestingly, even for HIV, even when Phyllis, Max came to Botswana, one of the key leaders that participated in shaping the nation's response were veterinarians, the likes of Dr. Masupu. So when COVID happened, we just went back to that and said, for instance, the gentleman I was deputizing was in retirement, a vet. So he came and provided leadership. And I don't know people in the animal agriculture side of things in Botswana, so he was very useful, even as we were drawing up maps for COVID-19 containment in the country. And it kind of made sense because if most people are farmers and they know how the country is demarcated and they know how movement can be restricted and they know how to move from one zone to the other where the main points of entry are, then when you start to shape a response that speaks to something they're familiar with, it sort of made a lot of sense. So, in terms of community engagement, when we started shaping the COVID-19 response, we looked up to people who had done a lot of HIV work in Botswana. And we look across board. We didn't look only at people who were doing bench work. We looked at people who were analysts, whether they are epidemiologists. But for us to truly come up with a response that engaged the community, you should just I don't know if it's available online, look at the formation of the Botswana Presidential COVID-19 Task Force. Although it was led by the president, and we met maybe twice weekly, with the president, the vice president, majority of cabinet, chiefs, business leaders, members of the community, members of the different religious denominations. I think there were a little over 100 people who met almost twice a week. And the whole idea was we could not form an appropriate, acceptable response that did not speak to the values, the expectations, the history of the people we were putting a response for. And beyond that formation, we had to travel. Despite there being COVID, whatever mode of transport we had, we went to all parts of the country. Why? To meet with the community, to meet with leaders, and take account for what we are describing to them and asking them to do, and hear from them what their concerns were so that we could shape a response that was acceptable to them. I believe we virtually met with all regional district councils to explain to them and answer their questions. I think we met with Parliament, we met with the House of Chiefs on multiple occasions to explain to leaders in the community what it is we were doing. So it was very, very critical in Botswana to do that. We engaged everyone by putting together an amazing crisis communications team. And because it was the first time in the era of social media that we had a disease outbreak, we needed people who understood and could track, follow sentiments, and let us know what it is. You know, I remember there were times when I'd come in excited because there was a new variant that had just been discovered, and I wanted to go and talk about it. And the comms team would sit me down and say, well, that's not where the nation is today. Today, people are talking about XYZ. That's what you need to go and address. And that really, really, in a big way, contributed to a response that was responsive to what the people wanted. I remember that in certain instances, we had to even unpack our different audiences. When we went on national TV twice a week, we also plugged on and streamed live on Facebook for the young people. We plugged onto national radio for people in rural communities who could only hear us or know what was happening by listening to the radio. So we knew who we had to talk to. I don't recall a single national address that we did in English. If we had a PowerPoint presentation, it would be in English with all the fancy graphs and everything, but the spoken, the delivery would be in the local language. So there's so many things that we had to think about to make sure that the response was appropriate.
Thank you. And this clearly, this again, multi-sectoral, laborious, sustained engagement across all sectors, and particularly with communities affected, led to what was very apparent to me, a much higher level of trust in government, trust in the guidance that you're receiving, and hence very high uptake of vaccines once they were available, use of masks, and overall compliance with the public health guidance. So congratulations to you and to Botswana on that. Thank you very much. And we'll be coming back momentarily to you, but Linda Gale, how are you?
Good. Thank you, Shaheen.
Okay. So maybe you can similarly reflect a little bit on how you ended up being where you are and why, and also then move into discussing the importance, as you see it, of civil society and community partnerships in the HIV response in South Africa, and in particular as it relates to HIV prevention in adolescent girls and young women.
Thanks, Shaheen, and a real pleasure to be part of this terrific panel. Greetings to all. And I'm aware that I probably contribute a good number of those 5 decades you were talking about earlier, but it's a real pleasure to be here. So it does take me back right to the very beginning of when our epidemic took off. I am born and raised in Zimbabwe, actually, but did my medical training in South Africa and went off very happily to become a geriatrician in a very rural part of northern KwaZulu-Natal. And of course, that was just when the AIDS epidemic was truly breaking. And it was becoming apparent that South Africa would bear a very large burden of the Southern African HIV epidemic. And right there, it was clear to me as I realized that everything I'd learned at medical school was not preparing me for the incredible onslaught of a new infectious disease epidemic, that I changed course and went back to medical school to become an infectious diseases doctor and pay a lot of attention to HIV and TB, which has been my journey for the last coming on for 25, 30 years now. So it's been humbling on so many levels, because I think there are so many firsts with the HIV epidemic, and perhaps most notable is the very absence of what Mosapelli has just been describing. Leadership from government was so absent in the early parts of the South African epidemic. And it was extraordinary to my mind. And as I look back, I'm still amazed at how civil society filled that void. And moved in a way, and when he used the terminology a movement earlier in the previous session, and truly I think we saw the enactment of a movement in the country that I have never seen in any field of medicine or subsequently to the same extent. And so that really, I think, showed me just the power of civil society and community. And I think such an important lesson that how it can be an incredible force for the good, and if left out, how we lose out on exploiting a very important ingredient in our public health response. So being a clinician, a treater, as well as a preventer and a researcher, I think that was, I was so lucky, I think, if there's any luck in the HIV epidemic or any silver cloud, I was so lucky to from the very first beginnings to understand the importance of community. And I know, Partners Health and other incredible organizations in the HIV movement have also exploited that incredible ingredient of the power of community. So I think from there, we saw activism following into advocacy that led to access, that led to literacy, that reaching every single sort of corner of South Africa with this new element of antiretroviral treatment and the power and the life-changing impact of that. That was able to really, in almost a political movement, and if Treatment Action Campaign has to be, really revered in this regard, that they treated it like a political movement. We had just come out of the extraordinary time of apartheid, where political movements had reached into all kinds of corners of South Africa. Similarly, they used that same kind of cadre deployment strategy and was able to reach really every part of South Africa, because of course HIV had ravaged the whole of South Africa and continues to do so. And it was through that we now, have, even in the face of a complete lack of government support, almost 5.5–6 million people now on antiretroviral treatment, that I don't believe could have been done without the basis of that civil society movement and strength. And Shaheen, I know close to your heart was the vertical transmission sort of movement where women voted with their feet. And I still remember the campaign of save a life for the cost of a single T-shirt, if you remember. So a nevirapine pill cost, something that a very cheap T-shirt would cost. And this is what we really promulgated to try and get to reach as many pregnant women to really prevent vertical transmission. So those are the days. And I think out of that was born task shifting, task sharing, and this real recognition that community can be an equal partner in the service delivery that we have to do. And every day, I really hope that HIV will become the poster child, the playbook for diseases and for epidemics in the future, because I think this is really what has led to us being at a place now where we start to see life expectancy turning, where we do see people on treatment, where we do see U equals U in a way that we can now gain secondary benefit from antiretroviral rollout and begin to look at primary prevention too. So, I unashamedly, I think the HIV success has been on the back of extraordinary community engagement, in community involvement, and importantly, community leadership. So
Thank you, Linda Gale. That was a really remarkable and powerful testimony and over to a really remarkable period in time. And this brings me to actually back to Maureen. This is a point that you had made. I actually want to turn now to focus a little more on equity and inequity, and also maybe what we here in the US and the global north can learn from our partners in Africa and elsewhere. I think we have a tremendous amount. We've already learned a lot, and we need to take that to heart and much more to learn. And you had, in a separate conversation, mentioned the power and importance of community participation in service delivery, not as service recipients, but as people who can participate in solving the problems. And I was hoping you could reflect a little bit about that. And then also, I'm just gonna make this a two-part question, maybe talk as well about access to diagnostics and medications, which we know is painfully inequitable globally, and what you have seen, what you have seen in terms of lessons that we've learned from HIV activism with regard to increasing access to life-saving HIV treatments, and your, in your current role with the medicines patent pool, what that might mean for other conditions.
Yeah, thank you so much. I think it's important, since we are talking about, advancing equitable partnership, I think it's important to acknowledge that when you talk about, advancing equitable partnership, it goes beyond just, providing fair opportunities for partners to collaborate. It's about being intentional in acknowledging, the underlying inequalities that do exist, so that the partners that we are bringing to the table can fully participate, but also reap the benefits from those collaborations. As Linda Gelbecker is saying, are we equal partners? When we bring everyone else on the table, are we coming as equal partners? And what I mean by that is that, and this is also something that we've learned from the HIV field, when programs, programs are being designed, research is being, whether it's research concepts being designed, it's always important to make sure that they are effectively addressing the local challenges. I think we heard from Dr. Auma this morning about, listen to the priorities of the African countries, and the same applies to communities. Listen to the priorities of the communities. When we are involved, when you involve communities, in the design, in the planning, they bring variable insights in terms of what works and what does not work, We've seen how communities have actually provided variable, feedback on, for example, delivery mechanisms. What works for them? Do they want to access services at the facility? Do they want to access services at the community? They have also brought valuable insights in terms of effective approaches that work to addressing the existing challenges that do exist. I think in my 13 years of HIV work, I've had the opportunity of engaging different stakeholders, health care workers, regulatory bodies, policy makers, funders, and what I've noticed is that, sometimes all these stakeholders may share an overarching goal, let's say reducing new HIV infections. But when you look at their priorities, and approaches to achieving that, they differ significantly, And I'll give you an example of what is happening. Allow me to, for example, with the dapivirine link, which is an HIV prevention tool, that was, produced, women participated in the studies, it works, and what we are hearing from women is that women want, that the ring. But then when you talk to funders, when you talk to policymakers, you kind of hear different stories, And part of the reason why there always this misalignment, in priorities, is because of that lack of collaborative planning, consultation with all different stakeholders. But when you bring all the stakeholders to the table, plan together, implement together, the results have always been remarkable, I think for me, also just going back to the question that you asked about, what has been the role of activism, for example, in increasing access to affordable medicine or ARVs. I think there's a history to that. We know that back then, I think early in the 90s, when Africa was bearing the huge burden of the HIV, when drugs were not available. They were first available in the developed countries, right? Super expensive, the monopoly that, Winnie talked about, pharmaceutical companies, they were holding the patents. The drug was ridiculously expensive, but it took a lot of community activism, right? Pushing back, court orders, right? To fight back those, patents, those monopoly. Of course, it took years, but eventually we had access, right, to life-saving medication on the continent, which is why I think for me, I'm glad, I'm so excited to be part of the community advisory panel at the Medicines Patent Pool. And I like that in their strategy, one of their goals is, to increase innovation, but also build capacity. They talk about building capacity, local capacity, manufacturing capacity, and I think we've heard a lot about that from Dr. Awoma, from Winnie also. She mentioned that, and I think I liked when Dr. Awoma said when an outbreak is small, it doesn't usually attract the attention that it requires. For example, it's interesting to hear that we still don't have, like, for example, medication for mental health, right? So Medicines Patent Pool, in their strategy, they want to, at least promote, initiate or motivate that innovation, so that we can also, pharmaceutical companies can also start investing, in the discovery of those great diseases, right? Talk about, local capacity within the African continent. Their plan is actually to make sure that they are also supporting efforts to build that local capacity. And I think as a community representative, being part of that, advisory panel, I feel like I take that as an opportunity to continue raising the voice of those women, the ones that keep pushing me, don't give up, keep pushing, right? To bring to the table the voices of the women to say, we can't repeat the history of how we fought for the access to HIV medication, right? We have to make sure that we are doing the right things. And I would like to take the opportunity of being part of that panel to influence how patents are being negotiated. So for me, it's a great opportunity to bring the voices of the community into that conversation, so that communities, regardless of where you were born, where you are, everyone has access to to the medication that they need to address their challenges.
Thank you very much. And I think it's impossible to overstate the impact of HIV activism and advocacy in terms of access and where that has brought our global community with regard to treating HIV. I will say that I, for one, was profoundly disheartened and dismayed by the profound inequity around COVID access to COVID vaccines, therapeutics that played out globally. I think we thought we were farther along. And so I think, Mosopele, you lived through this firsthand. I don't know if you have any reflections on what major steps we globally need to take to do better as partners, in both with regard to access, as scientific collaborators and partners. What do we need to do to better? What are some action items for us?
Thank you very much, Shaheen. When we were dealing with this and getting stuck in terms of getting vaccine doses, I thought to myself, we have global rules around, for instance, financial transactions globally. And we gray list countries, we do all sorts of things. We have global rules around movement of people, migration. Even the poorest country, people living and entering that country use passports, right? So, I asked myself the question, why don't we have global rules around things that will save all of us in the face of a pandemic? It's just baffling where our priorities are, that we can get it right to regulate movement of people or financial transactions globally, but we can't come together because even when we talk about, let's open a production site in Botswana or South Africa or Rwanda, well, when that outbreak happens, Rwanda is going to embargo the export of the product to save their people first, if there are no rules that guide how collectively, after investing in whatever infrastructure to save the global population, the same thing is going to repeat itself in nations. So I think what is really, really missing is the relevant bodies coming together and say, what are going to be the global rules around investment on XYZ to help us address our global pandemics? And that will range from testing. I mean, when COVID broke out, I remember that there were nations, for instance, fortunately, places like Botswana wanted to and could buy testing platforms, but there was an embargo. We couldn't get them in. Certain instances we paid, but things didn't get delivered until there was oversupply in the nations where those manufacturing companies operated from. The same thing applied with vaccines. You will all remember that the countries that paid, but we never got the doses until there were some that were expiring because they couldn't move out of the storerooms in certain countries. So I think we need to have some kind of rules globally for how we would do this with the next pandemic. I think counting on the goodwill of a pharmaceutical company X or Y, I don't think it will get us far, because even when we come together, give an example with COVAX. COVAX had rules for how they were going to distribute vaccines. So in certain instances, the distribution model, when we costed our vaccine rollout plan in Botswana, if we had followed the COVAX path to procuring vaccines, we were going to have one of the most expensive vaccine rollout programs. Do you know why? Because they will deliver the first 2.3 million people, right? So if they said we'll give we'll give doses to cover the first 5% or 10%, it means we have to put up the infrastructure to vaccinate people. And then you have to wait for 3 months. Do you dismantle that infrastructure or you maintain it? In a sparsely populated country, where almost half live in small settlements of maybe 5,000 to 10,000 people. So when we looked at it, even if the vaccines that we're getting through COVAX were going to be reasonably priced, when you look at the cost of deployment, it makes sense for us to go through COVAX. So if you look in the Botswana vaccine procurement package, 50 to 60% of what we got was bilateral negotiations with pharmaceutical companies, because we need to vaccinate quickly to cut the costs of the rollout itself. So sometimes even when we think we're trying to achieve equitable access, we come up with something ridiculously expensive that the ones that you're trying to facilitate cannot ultimately even afford to give people the jabs at the end of the day.
Thank you. Thank you very much. Unfortunately, I know we're close to, we have maybe a couple more minutes. Okay, thank you so much. I wish we had more time. So I'm going to see, I wish we had lots more time, but maybe Linda Gale, we can start with you and have each of you maybe give a couple minutes, 1 to 2 minutes of remarks as you'd like to close this out. Thank you. You're on mute.
The famous mute button, sorry. Just, my reflections as I've been listening to this is that maybe the most important thing I would say is that we really learn from history, right? And apply forward. Because I think there have been extraordinary lessons in just the last 2 epidemics, particularly HIV and in the COVID. There are, of course, epidemics that continue. Tuberculosis continues to ravage on, and malaria and many others. So, what can we learn and what can we take forward? And I'm an eternal optimist, so I'm going to believe that we will learn from our mistakes. And what makes me, optimistic is seeing how, I already mentioned, how we saw longevity and life expectancy plummet, in the mid-2000s in this Eastern Southern African region. And now we start to see that again begin to increase. There's no doubt COVID has set that back to an extent, but the fact that we've been able to come out of this and move back gives me a great deal of hope that we can apply lessons and we can move forward. But what I would say, the most important lesson to take forward is that there is no part of our community that we can leave behind. And as Mosapeli was talking, I was reminded that the next ingredient we brought into COVID, and I believe the same happened in other countries in this region, was bringing the private sector in to the public sector. So it was really a multi-sectoral approach. And then, as Maureen has already so beautifully illustrated, civil society had to come along. Now, we faltered somewhat in COVID-19 in bringing civil society along, but we did course correct at some point. So I'm hopeful that by applying the lessons of the past and taking that forward, we can actually do better in the future. And that's what I'm going to hold on to. But the lesson that this cannot be done by one single part of the health environment is an important one, that it really is multi-sectoral and that we do need to bring all the players along in order to get the best results. Thanks, Shaheen.
Thank you for that lovely statement of unity and cohesion. I couldn't agree more. Maybe Mosapeli, would you like to share last reflections?
No, thank you very much, Shaheen. I, like you, Linda, the ultimate optimist. I believe there's more good than bad out there. And I believe in the immense human capital that we have everywhere in the world. We just don't see it. So many smart, hardworking people that only maybe need us to just, remind them that they too are so important and can make a huge contribution to everything that we do. I think as a scientific community, we cannot live in a bubble where we don't realize the impact of misinformation and how some of the amazing discoveries we make or the science we publish is not impacting people. I think social media and sometimes politics interferes with the good that scientists have put together that can benefit so many people. I think we ought to start to think outside the box and look, either we ourselves acquire new skills or look for partners who can truly help us to effectively share and influence so that all the things that all the other scientists have worked hard to achieve can have true impact at a global level. I think the advances in science are so amazing, but if you look at the impact, it's not as good as it should be. And so what are we going to do? And I think that's a big challenge for all of us.
Thank you very much, Mosapeli. And Maureen, you have the final word.
Yeah, I'll be super brief. I think it's quite reassuring, as I said earlier on, to see how community engagement is actually being recognized, community engagement leadership. I think we've moved to a point where committees were just recipients of programs and all that, but we are now actively participating, engaging communities in the delivery of services. We are increasingly seeing the adoption of peer-led models, community-led responses, I think, which is quite reassuring. But that's not enough. I think we need to make sure that we are investing in communities so that they can be able to implement, to be equal partners in the delivery of services, in the design, in the planning at all levels. And then, like I said earlier on, when you talk about community involvement, it has to be at all levels. It's not about picking and choose to say, oh, this is too technical for communities. They want to understand. They do understand, right? We have communities at different levels. We have community members that are getting degrees at Harvard, at Oxford, that can understand that technical language. So I think for me, that gives me hope that there's that recognition, but it's not enough. We need to make sure that we are investing, we are creating that space and that community participation. It's not just tokenistic, but it's real. Yeah, thank you.
Thank you so much. All right, thank you all. Appreciate your attention, and that concludes this session. Thanks.
Thank you, Phyllis, Shaheen, Linda Gale, Maureen, and Mosopele for your thoughtful reflections. At this time, welcome everyone. We're going to be taking a meal break. We'll invite you to lunch, which is in a reader room across from me. And we'll return, for our virtual audience, we'll return promptly at 2:10. And for those of you who arrived a bit earlier, we had a slight change in our agenda. Regrettably, Dr. Suma Swaminathan was not able to join us, so we will return at 2 p.m. after lunch. Thank you.
How should this awareness inform how we go about our research and practice of public health? I am privileged to introduce our distinguished panelist and moderator, Ernest J. Barthélemy is Division Chief of Neurosurgery, State University of New York, Downstate Health Sciences University, and founding president of the Society of Haitian Neuroscientists. Joseph P. Gone is Professor of Anthropology and Global Health and Social Medicine at Harvard University, and Faculty Director of the Harvard University Native American Program. Lebohang Leopoldo Peko is Senior Research Fellow and Political Economist at the Trade Collective. She will be joining the panel virtually. Our moderator is Michelle Morse, Chief Medical Officer and Deputy Commissioner, Center for Health Equity and Community Wellness, New York City Department of Health and Mental Hygiene, and Assistant Professor at the Harvard Medical School. I turn the panel over to our moderator.
Thank you so much, Professor Achimpong, and thank you to the organizers of the conference today, the conversation, let's say. I would love to invite the panelists up to the stage. Well, the floor, let's not say the stage. And I say the floor because we are really looking forward to dialogue. I think even though we are in a very fancy space and place at the moment, our hope for this conversation is that it be very open, very honest, and very critical, frankly. I'm not sure if we have our colleague Lebohang online just yet, but hopefully she can hear us. And I might ask, actually, if you don't mind, can I start here? Okay. So I just wanted to share a couple of brief remarks before I jump into the questions. I want to start by saying that all of us in this conversation, and I think most of you, are in some way connected to public health or medical or social praxis. And it's so important for us to exchange ideas, critiques, concerns in a complex moment like we're in right now. I think there has been thankfully increasing scrutiny about the patterns of who thrives and who doesn't, and what the roots of those patterns are, and how they're connected so deeply to our history, our choices, our social hierarchy, and many, many generations of patterns preceding us. As we know, how we define the problem is often how we define the solutions. And so we want to, in the conversation today, be clear, specific, rigorous in our language, and really bring a powerful analysis to this question of what does decoloniality in global health look like? So I'm going to actually start with a definition. This is just one definition, and the panelists are going to respond with some reflections to this definition in just a moment. So again, one example, one definition. In their book on decoloniality, scholars Walter Mignolo and Catherine Walsh define the term as a form of struggle and survival, an existence-based response and practice against the colonial matrix of power in all its dimensions. Decoloniality denotes ways of thinking, knowing, being, and doing that started with, but also precede the colonial enterprise and invasion. It implies the recognition and undoing of the hierarchical structures of race, gender, heteropatriarchy, and class that continue to control life, knowledge, spirituality, and thought structures that are intertwined with and made up of global capitalism and Western modernity. They also characterize decoloniality as undoing and redoing. It is praxis. The goal of decoloniality is delinking in order to engage in forms of life that we like to preserve, rather than the hostage of modernity's designs and desires, and of nationalist selection of the past and the nation, as well as cultural de-Westernization and political reemergence. A lot of words. I suspect a lot of thoughts are already coming up for many of you. And I'm going to kick us off with some reflections from the panelists. I'm going to move over here. And so I'm going to kick us off by asking our panelists to take a couple of minutes to ground us in your perspective on decoloniality and how you see it as distinct or different from decolonization. And I'm going to ask Ernest to go first, and then Joseph, and then hopefully Lebohang will go third. Just a few minutes of your reflections on that.
Sure, thank you. I'm honored by the opportunity to be amongst friends and luminaries in this field. And I'm in this conversation as a Black American neurosurgeon and a son of Haitian immigrants. So firstly, I have directly experienced racism in medicine, both overtly as well as in its many subtle forms. And currently, I have the opportunity to serve a large Black community. Also deals with impoverishment, other areas of social inequity at a trauma center in Brooklyn, New York. And sometimes, when my colleagues and I strive to provide the standard of care to our patient population, the structural barriers to doing that can seem insurmountable. And yet, I'm often struck by how similar those barriers are to barriers I've encountered in the global health space and the work that I've had the opportunity to do in developing countries like Haiti, where my parents are from, and Cuba, among other places. And there is this inescapable link, this colonial legacy, the impacts of which I think are incalculably huge, but we need to find a way to grapple with this. So Paul Farmer always reminded us that we start the social diagnosis with the history of the present illness, right? And I think certainly those of us who are physicians, or even if you're not a physician, you can immediately appreciate how critically important it is to deeply and broadly understand that history if you're going to find an effective and sustainable solution. So, so this is the conversation of the day if we are to advance health equity. And I'll end with the distinction between decolonization and decoloniality. I think several of us think of decolonization as a period of independence movements in most of the countries of Africa, okay, with the salient exception of Haiti, which started about 150 years prior to that, right? But otherwise, the 1960s and 1970s are what we think of as the decolonization movement, whereas I think decoloniality invites us to appreciate the living legacy of colonialism that we're still dealing with in all of those countries, as well as in Haiti and certainly here in the United States.
Thanks for that. I appreciate the opportunity to provide a perspective that contrasts a little bit based on the experiences of Indigenous people in the United States and other places around the world. So I'm a social scientist, psychologist, trained clinically, but really engaged in research. I'm an enrolled member or tribal citizen of the Aani-Grovant people of the Fort Belknap Reservation in north central Montana. And my work has been dedicated to trying to think and, in the end, rethink how mental health services might be better tailored to be helping to my people and other Indigenous people in the United States. There have been a couple of key moments in my career where things have become really salient that the typical conventional way of doing business might not apply the best. I remember one that's quite personal. My younger brother, who sadly is no longer with us today, approached me and said he was going through a really tough time, lots of struggles. He didn't really know what to do. Could I do therapy with him? I was a graduate student at the time, training in therapy. But of course, the first lesson of therapy is you can't do it with people you know or are close to or related to. There has to be a kind of professional distance in the way we're taught. And being a graduate student and never having thought to imagine this kind of request, I kind of stumbled and stammered and made some kind of comment about how it's really not done that way, and maybe the IHS counselors could be helpful, at which point he completely closed down and sort of said, "Why would you think I would trust anyone outside of this family with my problems?" and turned away. And this is just one of an enormous variety of experiences, orientations, and perspectives that complicate the psychological mental health services endeavor when it comes to some of our people. And so we often hear enthusiasm for decolonizing global health, decolonizing public health, decolonizing mental health. And I just want to remind us that there are varieties of colonialism. There's the kind of colonization that we've just heard about, which had to do with a moment of decolonization in which people who had occupied for a long time were sort of sent home. But the condition of the United States and of Canada and lots of the former, British Commonwealth nations are ones in which settler colonialism is probably the variety of consideration. And it has to do with the fact that folks came from wherever and plan to stay and have stayed. And so there is no formal decolonization from that. The settlers and their descendants are never going back, and it changes the dynamics of how we think about decolonization in such circumstances. In fact, it makes them quite difficult. It's almost a creative, perhaps even poetic endeavor to imagine what decolonization looks like under the conditions of settler colonialism. And I don't have the imagination to really tell you what that looks like. What I will say is that there are Indigenous scholars who have been very active in Indigenous studies who invited us to worry that the term decolonization has been conscripted for a bunch of, anti-racist struggles, emancipatory struggles, liberatory struggles of all kinds that completely forget that Indigenous land has been occupied, stolen, and is still settled on in many ways that are illegal and ethical and in need of remedy and repair. And so the call from, say, Eve Tuck is decolonization is not a metaphor. Don't use it for your emancipatory struggles. We need to reserve that for the fact that Indigenous lands continue to be occupied. So in that sense, I really appreciate the shift to decoloniality, which has to do with kind of a state of being that probably all of us encounter, whether it's we benefit from true decolonization or we're in settler colonial situations, which has to do with a state of being that is shaped by these legacies and histories, and that presents all kinds of constraints and limitations. And indeed, psychological constraints, such as not only deep senses of shame and inferiority, but also a kind of paralysis that can come with certain mental health problems that accompany colonial subjugation, like addiction and trauma and suicide, the sort of things that we see fall out of conditions of oppression all over the world. And so the opportunity to think about how to enter into decoloniality is really welcome. So thanks for that.
Thank you. And I think we have Lebohang online. Hopefully you can hear us, Lebohang. If you want to unmute and share your initial reflections on this question of what does decoloniality mean to you? How might it be distinct from decolonization? Bless you. Anything you'd like to share for a few opening remarks? You're welcome to join.
Thanks, Michelle, and to the colleagues. It's good to use virtual spaces because we can be in rooms together, even across great distances. So I think I want to begin by segueing into affirming everything that my colleagues have said, and also segueing into a problematic or a provocation. And I think it's around terminology. So if we understand colonization as the occupation, the total occupation of lands, of languages, of culture, and the extraction of archives, of histories, her stories, of people, of geologies and geographies as well. And if we understand it as the complete erasure and the impulse to remove all that is indigenous to a space and a place across time, and it doesn't need to be linear, then I suppose then we can appreciate then coloniality as the ongoing ontological, epistemic, and violent economic, cultural, linguistic manifestation of the same. And one of the concerns that I've had recently is in the colonization of coloniality and decoloniality. So one example is this notion of apartheid, vaccine apartheid that emerged over the last couple of years during the distribution of the COVID vaccine, or the lack thereof, which is a story for another day or later in this conversation. And the concern that I raised there and that I'll raise here is that when we speak about a construct like apartheid, apart from being, I think, incredibly conceptually lazy, it means that we're taking a construct similar to one like coloniality or colonization, and we're not giving it the political power and meaning and potency of what it was and was not, what it is and is not, and what it did and did not do, and the way that it has been memorialized on Black and brown bodies. And I think the other piece of this is that if we appreciate that apartheid is an ongoing phenomena, it is not over. We can't speak of post-apartheid. We cannot speak of the notion that the racialized inequalities that we're experiencing, the social apartness, the political, financial, and economic destitution of African people and the African majority in this country are in fact over, and that these are colonial realities and colonial factors. So it's not in the same way that it is not accurate to characterize a country like South Africa as a post-apartheid state. It is not a decolonized state, and I don't view it as a decolonized space. I view it as a compromised position that was negotiated into existence for a whole bunch of compromised reasons. So if we speak of a construct of apartheid and then try to superimpose it onto financial apartheid, vaccine apartheid, climate apartheid, as though the original construction of apartheid has itself been resolved, we do it a great disservice. So I would view coloniality and colonization and decoloniality as constructs and phenomena which are in constant dialectical tension with each other. Because in as much as we would like to view coloniality as a linear project that is constantly moving forward, there are always factors, constraints, demands of white supremacy and power that always want to retain, reinstate, reinscript other forms of colonialism and coloniality, other forms of occupation, financial occupation, policy occupation, discursive occupation, and so forth. And this is really a global project that is epitomized by the US imperial state complex, by the European Union imperial state complex, and to a much lesser extent by the sorts of junior adjacent supremacist powers that are also trying to gain ascendancy. So I view coloniality as a tension with which we are wrestling with an endpoint which is not finite and which is not clear, particularly because the language and the processing is constantly being derailed, reconscripted, remarginalized, and redefined in ways that are often perverse and far away from the radical and important underpinnings of Black and brown power from which they emerged in the first place.
Wow. Lebahang, you're getting applause in the room. I hope you could hear it. And hopefully everyone online heard it as well. What an incredible way to start this conversation today. I can't thank all of the panelists enough for just going straight for the heart of the issue immediately. It gives us more time to be in dialogue, so get your questions ready. I can see questions on your faces already in the room. But the next round of question that I want to put forward for the panelists to respond to and to share your reflections on. So we said we want to talk about decoloniality. We want to be clear about our language. We also said we want to talk about some examples of decolonial work. And then we also really, again, want to be in dialogue with everyone who's here today, both in person and online. And so to that point, I'm going to kind of shift us over to what is, I think, a very challenging question. And I don't want to make it seem like there are immediate, easy, direct solutions to the problems and the challenge that we have just been describing. However, there is just incredible experience on the panel, in the room, online. If you all would be willing to share some initial reflections on some examples of decolonial work that you think are worth mentioning, or decolonial work that is in process that is worth mentioning, or that's beginning that is worth mentioning, would love to hear a round of reactions to that. And throughout the conversation this morning, there was something that was coming up for me was there's a lot of conversation right now about inclusion. There's like the diversity, equity, and inclusion world. There's, bless you, lots of allergies today. This question of inclusion has been coming up a lot in health equity work, racial justice work, et cetera. But it's quite different than
centering. What does it mean? What's the, this question of what's the difference between inclusion versus centering is something that I think is really potentially part of what might come up in the examples that you share today. So for this round, I'm going to ask Joseph to start, and then I'm going to pass it to Lebohang and then to Ernest, just for examples you might want to share.
Well, thanks for that. And this is where the rubber meets the road. So it's probably really important that we come up with, concrete examples that try to illustrate better what we have in mind. And I do appreciate the term centering, because a lot of the work that I do when it comes to mental health is to try to partner in collaborative fashion with tribal communities to rethink how helping services for addiction, trauma, suicide, for example, might suit populations better than the latest evidence-based practice. And so sometimes that means centering indigenous knowledges, indigenous traditions. I'll give you an example. I partnered with the Substance Abuse Treatment Program on the Blackfeet Nation, which is a reservation in Montana, and they ran their own accredited inpatient substance abuse treatment program. They also had outpatient services for their own tribal members. And I approached the director. Basically, they do what most Indian communities do, which is to import in somewhat boilerplate fashion standard residential addiction treatment. That's based on the first 5 steps of the 12 steps of Alcoholics Anonymous. That's all about group therapy. They had a cultural counselor. They had a couple groups that addressed cultural issues. But by and large, it was brought in from the outside, and you might say dressed in beads and feathers to try to appeal to local folks, Indian folks from the state. I approached the staff and I sort of said, what would it be like to invert this method and this model? Rather than starting with something built from the outside, what about returning to Blackfeet therapeutic tradition, sorting out what that might look like, and then figuring out secondarily how to harness that for addiction treatment purposes? Well, they got quite excited about that, and we spent a couple of years coming up with a program. Essentially, the important thing about such programs is that, number one, it's deeply participatory. I think in some ways that's the major antidote to coloniality, is participatory engagement. And then really, it wasn't the addiction treatment experts who called the shots. It was community members who knew something about Blackfeet therapeutic tradition, who are not by and large credentialed as mental health people. And so these were traditional people, ceremonial people, people who kept the sacred bundles for the Blackfeet people, and what were known as the Crazy Dog Society members. What did they come up with? It took a while to get it all sorted out, but they came up with what we called the Blackfeet Culture Camp, which was an effort to, in the summertime in particular, set up a camp in teepees out in the bush and to offer to clients, addiction treatment clients, something like what their pre-reservation ancestors might have lived like. So we lived in teepees. Very first thing was to conduct a pipe ceremony after having set up the camp. The next day, the first thing was to build a sweat lodge in the bush and have a sweat lodge ceremony. And then to visit sacred sites and to harvest sacred medicines and to different things like that over the course of the remaining program. So there are a few lessons to be drawn from this example. The first is that it was sacred, not secular. That is a huge difference with mental health services in general, which are typically not sacred or not about religion, don't depend on some sense or understanding of God or other kinds of higher beings, don't depend on prayer and ceremony. Second of all, it was not led by credentialed, professional, trained people. It was led by the Crazy Dog Society. Third, it involved coming together of crazy dogs and addiction treatment clients such that no one really knew who was who. There was no clear demarcation between client and people who were putting on the program, and no one really cared about that because in some sense people thought like this was a good program that could be therapeutically beneficial for all Blackfeet people, whether they were now contending with addiction or not. Finally, it's really important to understand it looked nothing like conventional counseling or therapy. There was no cast your feelings into words, no tell a coherent story about your life and how addiction has ruined it, no confess that you're an alcoholic, nothing like that. In fact, if anything, this was about, in some ways, not only rehabilitating a robust, positive Indigenous identity, but also about connecting into socialization around ritual and traditional ceremonial practices with the crazy dogs, which in fact, sort of person by person, ends up rebuilding a nation. And so it's much bigger than treating an addiction client. It's about actually intervening in the ongoing and eventual futurity of a tribal people.
Thank you for that. Lebohang, will invite you to chime in next for an example if you're ready.
Sure, I am. So I'd like to use two really briefly. So the one is around decolonizing the curriculum in South Africa. So that was the movement Fees Must Fall that I'm sure many people in the academy will have been aware of, which came to a head in 2015, spearheaded by various students across the country. And I don't want to name one or two because that also privileges one or two institutions above and beyond the rest. But the whole notion is this of what it means to be an African university that is decolonized, or what an African curriculum, and Africa not being a country, but what it would look like to see ourselves. So the demand for young people was to see themselves inside the curriculum. And this also meant that, you know, in then decolonizing the curriculum, how to then replace the kind of the canons and the assumptions about canons that have been made and taken as being. And I mean, decolonizing curricula is incredibly difficult. It's much more than just, we're not going to read Shakespeare anymore. It's also the approach, it's also the iteration, and it's also languaging, linguistic languaging, political languaging, discursive languaging, and so forth. It's the forms of learning and the forms of exchanging of knowledge, information. It is completely upending the assumption about who is a knower and who is a knowee, so to speak. And I think that what happened as a result of that is, though, even though as scholars have said, decolonization cannot be exhaustively practiced, I can point to one or two, really important examples. So one of my good friends, Professor Sipogazi Magadla, has recently supervised several students at the University of Rhodes in isiXhosa, which you'll know is one of the 9 indigenous languages of this country, minus the 2 colonial languages, including the one that I'm speaking in now. And I think that what this has done is that it has also enabled us to see and to hear and to understand and to rescue archives which are often held in language and which cannot always be found in, what has to be said, languages that came and arrived on a ship and were forced down our throat at gunpoint. The other point is that another good colleague of mine has then decided that he's retiring your classical sociological scholars. So you'd always have Weber, you would always have all of your positivist, and he is using the works of a certain guy who's one of our greatest philosophers in South Africa, and he's decided to use that as his entry point into understanding sociology from a completely different standpoint, an Afrocentric, Afro-centered, South African-centered standpoint, which then shifted around from a dead white guy in Germany or in Russia, and recenters it into realities, ontologies, which are rooted in something that is much more familiar. And I think decolonization is about a re-acclimatization of the familiar. The other thing is completely different, but it was also a series of demands by Black feminists, African feminists during the first part of the COVID pandemic, because similar to the construct of post-apartheid or post-colonialism, I don't believe that we're post-COVID either. And this was really a demand for a different kind of imagination. And I think this is where Black feminism offers a really useful approach and a reproach to colonial constructs, because we've been doing the work of reproaching the construction of states, the construction of racism, of heteronormative patriarchy for a really long time. And these demands really suggest, well, if demands can be suggestions, but these demands basically state that we want to see food sovereignty, which is rooted in indigeneity, indigenous women-led food sovereignty, tax justice, ecological work, and it's really grounded in feminist organizing and a different way of seeing and viewing and arranging power. It also suggests that the credit crisis was enormous and pervasive, and it is making demands that states, and it was actually originally written to the envoys, the African Union envoys, as appointed by current President Cyril Ramaphosa when he was the chair of the African Union, who were asked to go and look for money from the World Bank and other institutions. But basically, it was a suggestion that we need to rethink the way that credit is arranged in a ways that it actually privileges the sort of normativity of capitalism, capitalist power, and masculinized power relations, which continue to bail themselves out whilst languishing, whilst leaving the people who actually subsidize unpaid and paid or low paid labor, the Black and brown people, especially Black and brown women around the world, who actually subsidize the economies as we know them. So basically, we suggested that even though that COVID has not flattened the universe because privilege still prevails. But what it does do is that it means that we want to see decolonized policy and power relations, and in a different manifestation of institutional and logistical arrangements in reframing the world that we want to see. Obviously, we are now living in a quasi post-COVID world. Not many of our demands were met, but I think that it's fair to say we put some hot fire under their feet for a second there.
Thank you. Hot indeed. Thank you for that. And I do hope we'll get to explore a little bit more about this question of institutional relationships that you brought up and that many of the panelists have brought up. Ernest, I'll pass it to you for a final reflection on examples.
Sure. I really appreciate Lebohang's characterization of the dialectical tension that we're in. So it has me thinking about the examples of the decoloniality side of that conversation. And neurosurgery, neurosurgery spaces have been actually historically, but not so historically, dominated by white males. It's a white male dominant space, right? And that is thanks to this incredibly successfully damaging report by Abraham Flexner and all the great money he had pumped behind it by Carnegie and Rockefeller, did a great job of keeping Blacks generally and Black males specifically outside, certainly of surgical spaces, among other medical spaces. So even going through my own residency, earlier years, I always thought to myself, it'd be wonderful to have a community of other Black neurosurgeons to connect with, to find mentorship, et cetera. Well, that finally got generated following the tragic murder of George Floyd by police officers in the way of the American Society of Black Neurosurgeons. It's only a couple of years old, but it's slow, it's coming, it's growing, and I was thrilled to discover that I wasn't the only one sort of suffering in my own thoughts about this as I went through what life was like as a neurosurgery resident. So that's one example that comes to mind. A second is the global neurosurgery field that I'm in, that probably has propelled me here, and that's part of the growing global surgery conversation. And it wasn't too long ago that the very idea of global health was sort of unwelcome in neurosurgery spaces. It's like, this has nothing to do with neurosurgery, probably for the reasons I've just mentioned. And that has shifted, and it's been powerful and it's been palpable in all areas of global surgery in general and in global neurosurgery in particular. And at the same time, as we have pursued the conversations in the midst of that dialectical tension, we have had to face the fact that the dominant voices in global neurosurgery are the voices that have always dominated. And so it has not been as transformative as what we hoped it would be. And I think what is promising is that we are starting to talk about that, write about that, publish about it, starting to do bibliometric analyses and recognize, hey, who is the first author on these papers? Who's the anchor author on these papers? Where, how is this, where are the research questions coming from? Who benefits, et cetera, things like this, both on the research side as well as on the clinical side. And that continues. I've been fortunate enough to be part of these conversations, and they continue at our national and I would say more so international organized neurosurgery meetings, a bit more than the national ones in the US. But those conversations are alive and they're well and they're growing. And at least in the US, the American Society of Black Neurosurgeons is helping with our decolonial side of that tension. And then I can speak a bit more about my experiences with the Society of Haitian Neuroscientists, which is an experiment that I created after a lot of frustration dealing with the cyclical socio-political instability in Haiti and trying to build a neuroscience community there. And I thought, well, part of the problem is that so many of the Haitian neuroscientists are not in Haiti. They're like me. They are outside of Haiti. They've been driven out, or our parents have been driven out for a variety of reasons that have everything to do with this conversation. So I thought, well, what if we bring all these neuroscientists together and try to reverse the brain drain, okay? And so we've been doing that. We've been working on doing that. We have a membership of just over 100 members. All members are of Haitian nationality, ethnicity, or culture. We're in 7 different countries, and we exist to advance neuroscience in Haiti, to promote the welfare and well-being of people suffering from neurological, neurosurgical, and mental health diseases in all Haitian communities, and also to foster collaborations between Haitian neuroscientists. And within our work, much of which has been around supporting educational efforts, in the Hôpital Universitaire de Mirebalais, where there was a neurological training program. So we started to integrate our membership into the training of the residents and fellows there. And many of us started pushing education in Haitian Creole. So I won't go deeply into Haiti's socio-linguistic landscape and history, but that in and of itself was seen as a somewhat radical and Freudian move to offer education in Haitian Creole. And we've been pushing that. We've even done that with some of our new partners in Haiti, who we've met through the society. At the Association of Haitian Psychology, we partnered with them in the creation of a peace summit in the north of Haiti, and there was a lot of Haitian Creole used for everything from the neuroanatomy workshop that I taught there to a sort of reimagining of what Haitian Vodou really is about, why it's been demonized, et cetera, celebrating its fundamental cultural value and history and African cosmology, et cetera. So I'll pause there, but I think those are real examples of decoloniality.
Thank you again to the panelists for bringing the fire, the reality, the challenge. We're going to open it up for questions. We've got time for a couple of concise questions, and I see some hands already. And just a reminder, then the title of our discussion this afternoon, Decolonial Praxis and Health, Challenges and Priorities. I think we've heard a lot of the challenges. I also think we've heard a lot of incredible work that's happening that advances this vision of decoloniality in global health. So a couple of concise questions, and then I'm going to ask the panelists to close out with a minute of final reflections.
I'll make them very concise. I have one observation and one question. I just wanted to make an observation about the potential other side of conversation on decolonization from India. I live half the year in India, so I can tell you that right now, an extremely right-wing government is using arguments on decolonization to actually rub out our entire Islamic history. And only last week, all the curricula in India for high school students has essentially removed 700 years of history. So I think it's an interesting counterpoint that these arguments can also be co-opted by actually extremely regressive political forces. So just to keep that in mind. My question to you is, as a member of a very privileged university here, this one that's hosting this event, I want to hear your thoughts about what is the role of privileged universities in decolonizing the praxis of global health.
So far ahead of me. I'm so glad you asked that question. That was going to be my final reflection prompt question, actually. So it's great to jump into it now, and would love reflections from the panelists. I have some thoughts too, if there's time.
I'll start. So in the Haitian community, we're very excited when we found out that Harvard's 30th president would be a Haitian American, Black Haitian American scholar. And why did it take Harvard longer to have a Black president than the United States? Right? And that's 128 years after the first PhD is awarded to another Haitian American, W.E.B. Du Bois, right? Is how long it took for a Black president to be at the helm, which technically hasn't happened yet, right? It happens in July. And so even as we celebrate the victories, I think they should wake us up to how bad things are. And I look at the responsibility of an institution like Harvard, and there's a huge endowment for research. So I think one place to look is what are the questions that are being driven by that research endowment and supported, and who are the researchers? And I think that's a very important responsibility of the institution and the university. In addition to looking at, well, what are these structural barriers to equitable student representation in the various colleges in the university? So these are the first thoughts that come to mind.
I will briefly say that Harvard changed my life. I came here as an undergraduate, transferred as a junior, here 2 years on a Pell Grant. And so I'm forever grateful for the path that's put me on. I wouldn't be here today if I hadn't been there then, I don't think. Having said that, I'm at Harvard. I'm not entirely sure I'm of Harvard. I don't know if I'll ever be of Harvard. I don't know what it would mean for me to be of Harvard in that sense. I will say that I appreciate Harvard as a platform in which to articulate the advocacy that all of our Native and Indigenous mental health professionals bring when it comes to service delivery and funding and all the needs we have, which is to say that our traditions and our ceremonies and our cultural practices are in fact healing and part and parcel of what it looks like to help our people in a way that's anti-colonial or against the state of coloniality. And so the opportunity to say those things at a place like this is a real privilege. And it's one that I hope harnesses the concerns and commitments of my own people.
Debahang, did you want to jump in on this question, or shall we keep going? There may be an online question.
I will jump in. I will always jump in. Absolutely. So I just wanted to share something. I mean, the one is it's a quote by, another great majority world scholar, Chandra Mohanty, and she says, how does one theorize capitalist citizenship, and how is the university implicated in engendering this kind of citizenship? If the market provides the ethical and the moral framework for university life, educators and students exercise choices as consumers in a marketplace, not as citizens in a democratic polity. And then she goes on to say that thus wealth determines citizenship. Instead of people governing, markets govern. It is not the citizens who make decisions, it is consumers. So those who lack economic capacities are non-citizens. And this results in a profound recolonization of historically marginalized communities, usually poor women and people of color. And she goes on to say then that the university is basically the factory of this form of recolonization. And I think that it's fair to call, in many respects, universities like the University of Cape Town, which has recently suspended, or in fact removed, the second Black woman vice chancellor. It's fair to say that institutions like one of my alma maters, SOAS, the School of Oriental and African Studies, have extremely complicated and very, very difficult history. And of course with Harvard, who is graciously hosting us and graciously hosting a very difficult and a very, not controversial, but a very combustible conversation that calls for great personal courage, and I think institutional courage as well. But I think that what many of these institutions have in common is that in trying to decolonize, I mean, it just seems such a capacious as to stand for any kind of critical engagement with race and representation and representativity. It does also mean that they stand on the ground physically and viscerally of a lot of settler power. So there's a debate going on at the University of Cape Town around the lands on which the university stands, right? Which is the land which was taken from many communities in that area, where they've been cordoned off over the last 100 years, and many people, marginalized or dispossessed African people in the area, are not able to access those lands. So what is the role then of a university which reinforces coloniality in its own practice, which reinforces class power and class privilege and racialized class privilege in its own practice, where many of the of the faculty and many of the people, the team members, especially those who are lower paid, cannot even afford to send their own children to these institutions. And I think that the other thing is that there's a struggle to seize back a real control of all the means of what Ngugi wa Thiong'o calls communal definition. And so what does it mean then for a university like a UCT, like a Harvard, like a SOAS, like a Witwatersrand in my other alma mater in Johannesburg? What does it mean for them to grapple with the fact that many of their imprints, including their physical imprints of statues of colonizers and people like Cecil B. Rhodes, you'll probably be aware of that, Rhodes Must Fall movement, that many of these are sites of great violence, discursive violence, physical violence in many respects, at like the University of West Indies, where as our colleague Sir Hilary Beckles was telling us, several remains of our beloved loved ones who had been buried there were found as they were doing a renovation. So physical violence, and of course, intellectual violence. So it goes back to this dialectical tension for which I don't know what the resolution is, but I think that recognizing that the cure, the sickness and the cure, that cannot necessarily reside with the same people in the same institutions in the same way.
Okay, well, I think we've thoroughly explored that question, and there's a lot more that could be said. I did say we would do 2 questions, so I think there is one online question that we'll take, and what I'll do is, we won't have time to have the whole panelist group answer this question. What I might do is just ask you to integrate any reflections, the answer to the question, into your closing 30 to 60 second thoughts. So one question from online.
Hi, yes, thank you. This is a question from students in our virtual audience. How do you foresee the next generation of global health scholars carrying out decolonial praxis? What is the role of young people in pursuing these challenging equitable solutions in medicine, political economies, etc.?
All right, what a beautiful question. Thank you to the online folks for submitting that one, and what an exciting opportunity to think about the future. So for closing remarks, partially or not in response to this question, I'm gonna actually ask Lebohang to start us off, and then I'll go to Ernst and then to Joseph, just a brief closing reflection for us.
Thanks. I think I'm the only sort of civilian in that I'm not a health practitioner on this panel. I'm a social scientist, but I'm very interested in the notion of how health and the exclusion and the exclusionary nature of public health manifested itself over the last 3 years during the the earlier phase of the COVID pandemic. And I think that it gives us the opportunity to really reframe and to rethink the power of biopolitics, right? The power of bioimperialism and biocolonialism, and how these actually then aggregate to then contribute to the notion of who is and is not worthy, right? Who and the notion of personhood, which I think medical practice is also extremely concerned with, the notion of the sanctity and the sacredness of life, all lives, right? And that this cannot be mediated by economic access, racial access, by geographic access, by majority world versus minority world interest. And I think also to add that, all of this is linked to the racialization of capital, the racialization of who accesses markets, and the racialization and gendered access to those markets, and the right to be fully human. That is what I think really seems to emerge as well, even as we speak of coloniality and decoloniality. It comes down to the question of who is and is not human, and how has white supremacist power framed this hierarchy of humanity. So I suppose I'll pause there. Thank you.
Thank you. Ernest?
Thank you. Great question from the students. And I keep bringing back the idea of dialectical tension, and I would suggest how important it is for us to therefore create spaces for conversations like this, and also consider the importance of deep introspection. in these conversations and situating oneself, understand who are you in this conversation, by accident of birth, by accident of, where you grew up, things like this, and how might that shape the way you even listen when you're out there listening? Because listening, I think, is the key skill that the global health leader of the future wants to develop, and frankly, the leader of the future wants to develop, is the ability to deeply listen. And deeply listening requires you to recognize what gets in the way of working constructively with your partners wherever they are. So I think, consider this in your professional development, and then I'm going to borrow what I believe I heard from Dr. Anna Christina a bit earlier, around the possibility of learning from the global South. I think it's more than a possibility. I think it's very real. And even ask yourself, why is that such an audacious statement to make, right? And we want to move towards recognizing, no, that's exactly where we're going to figure out how to solve this. Like, we don't have what it takes, sitting up in ivory towers looking down, and trying to solve these problems, because that is the colonial side of this dialectical tension. We've got to really get outside of this matrix and start learning from people who really need to be the empowered and leading voices in this conversation.
Joseph.
Thank you. I love the question, and so it's a nice opportunity to reflect on it a little bit. One thing that has occurred to me in the work that I've done is that in some cases, the exact same program or intervention might be colonial or decolonial, depending on how it was arrived at and who had a say in its organization and deployment. And so I just want to underscore, I think what others are saying is that I do think that a participatory approach that depends sort of on a relational ethos is the way of the future and the way that decoloniality can be advanced. Certainly you have expertise. It would be foolish to imagine you would get into a field without any meaningful, useful expertise. The thing is, lots of people have expertise, and you don't have to have advanced degrees and have gone to Harvard to have expertise. There are people in our communities who have all kinds of expertise that has no credential and not even any acknowledgement or recognition from the broader society. And for these programs and interventions, whatever we have to contribute, to be relevant and useful and harnessed to ameliorate suffering and help our peoples, requires all of the expertise on the table and people in dialogue and a negotiated and well-reasoned effort to figure out how to apply this to that setting and this problem in this way. And so I just think the participatory approach is what needs to be underscored. I'm a little hopeful because the National Institutes of Health in the United States, at least some of the institutes, have had calls for research that fund some of the participatory part. I mean, the major problem is that usually grants don't pay for before the beginning kind of work, where you set up the partnership, where you would host a community advisory board, where you get the feedback and even consultation about what should the research question be, what methods are acceptable, what methods aren't, what would work best or meet the needs of this community best. And if no one's funding that, well, then it's not surprising that it's not happening. But some people are funding it at NIH, and probably it needs to become more the wave of the future, not just at NIH in the United States, but around the world. Thanks.
Incredible, incredible. Thank you. I'll just close by saying another word of appreciation to the panelists for bringing such direct, fiery, critical, honest reflections. We mentioned and talked about participatory engagement, sacred, not secular, familiarity. We talked about endowments and how they could be used. And I just think I would leave us with this question again of what is our responsibility for those of us as individuals, as members of elite institutions, for those of us who have and hold those identities. The question of partnership, I think, comes up over and over again, and that was a big question in the conversations this morning as well. Where do they start? where do they originate? How are they framed? What are the goals? Whose voice is centered? I think these are all questions that we can continue to grapple with as we reflect on what decoloniality might look like in global health. And the final thing I'll say, to go back to what Lebohang mentioned about Black feminism, Bell Hooks said, "We cannot cede the space to the fools." So let's keep pushing our institutions to do better. Thank you again.
Michelle, Ernest, Joseph, and Lebohang for this thoughtful and engaging conversation. Can you hear me? Great. Okay. Thank you. I would now like to introduce our final plenary session entitled Community Response to Emerging Infectious Diseases. This session was conceptualized in partnership with Partners in Health. Giving opening remarks is Alan Brandt, Professor of Medicine and Professor of History of Science at Harvard University, and the Interim Chair in the Department of Global Health and Social Medicine at Harvard Medical School. Professor Brandt, please take it away.
Thank you so much. It's great to be here today. I have to say, I really have been honored to be here in the room today. It's been a remarkable set of conversations. And I realize we're in kind of a new world, a small group here in the room, but over 1,000 who are getting to participate in this meeting via its hybrid nature. And for me, it makes the world a little bit smaller, and it punctures some of the potential pretensions of getting small groups together in universities to talk about important issues that affect communities in such a powerful way. And I just want to say, I really want to thank Louise Ivers and her fantastic group at the Harvard Global Health Institute. And as an inaugural set of conversations, I think this is just so promising. And unlike some of my colleagues, I sometimes do get discouraged and I have a potential for cynicism. But I have to say, listening to the remarks today and their probing and critical character has been so important to me, and I feel so fortunate to be part of this collective conversation. And in a sense, that's what the last session returns to, a theme that has been threaded in and out of all the conversations today: community response to emerging infectious diseases. There's a saying that all politics is local, but I think in a similar way, all global health is local. And by that, I don't mean just contained in small communities, but it has to start at communities where the need is greatest, where people are sick and suffering, and we see the embodiment of coloniality, racism, slavery written into their bodies. And it's community engagement that is the spark that has the potential to radically change global health. And I should say, radically change institutions like elite universities like Harvard. That part of what we're talking about, and I think in a sense, Joe Gahn just said this, universities can imperialize and colonialize the world, or they can be potentially used, and I see the glimmer of this in the room today, as a force of global good. And that involves the radical reconsideration of what universities do, what kind of knowledge they produce, and not only what kind of knowledge they produce, but the ability to deliver that knowledge in ways that affect people in the greatest need around the world, certainly in the global South, but in a rich country like the United States, where disparities are so profoundly significant and growing. So there is so much for us to learn from the experience of the work that is done in communities. We have really a fantastic panel to conclude today. My colleague Joya Mukherjee, who's been a central leader at Partners in Health and is my colleague in the Department of Global Health and Social Medicine at Harvard Medical School and in the Division of Global Health Equity at Brigham and Women's Hospital. Jean-Gregory Jerome, who is the Senior Advisor for Health Systems Strengthening at Partners in Health. Bizola Ojikutu, who is currently the Executive Director of the Boston Public Health Commission and has worked tirelessly during the COVID pandemic to engage communities. And very fortunately, this panel will be moderated by Helen Branswell. And probably everyone in this room knows Helen Branswell's work. But in a time of misinformation and brutal disinformation intentionally delivered to confuse and distract from the critical issues of what science and medicine can do and can do effectively, Helen Branswell has been a real visionary and light and one of the great writers. And I think when we write the history of the COVID pandemic, her work and the work of her colleagues at STAT will be recognized as a clear voice in the midst of disastrous debates. So let me call upon the panel and Helen Branswell to moderate. Thank you very much.
Hi, good afternoon, and thank you so much for that very, very generous introduction. I'm really looking forward to this next 45 minutes or so. I'd like to explain for a second how this is going to work. I'm going to ask some questions, and I'm certain that as you're hearing the answers, you'll be thinking of your own questions, and sort of maybe 15 or 20 minutes into the discussion, I'll ask for questions from the audience, so please do make notes and have questions at the ready if you want. And then we'll close at the end with comments from the various panelists. Please also, if you're not hearing us, wave your hands. You know, we tend to drop mics sometimes, and if you can't hear us, please let us know. I think to start, it would be useful to sort of unpack the premise of this panel a little bit to explore what we're going to be talking about here regarding community engagement and community-centered responses in an outbreak setting. So I've asked Joya if she could give us an explanation off the top. How can, could you start by maybe giving us an example of how this works from your own experience?
Thank you, Helen, and thank you to Louise and the staff at the Harvard Global Health Institute. This has been so great. Each and every panel, I've heard something that I wanted to say, so I'm not going to repeat the words of every other panelist. But I will say that there is a brutality to the global security architecture. There's a racism to the global security architecture, and there is an imperial nature to outbreak control. And if we are to fight for justice, we have to be involved in community-centered approaches, but that often we talk about the top-down approach and the bottom-up approach, and we have to reject that there is a top and a bottom. The approach to epidemics must be fundamentally a collaborative approach, bringing people from all lived experience into the mix. And in my own work as a physician, I think what I say to our team is, I have carrots. If we are working together to make the stone stone soup that we will all eat. As a physician, I can bring one thing, it is carrots, but I need the driver to bring the meat, and I need the person who's suffering to provide the salt. And so we have to develop a collaborative approach. In our first work in HIV in Haiti many years ago, we started by just treating the sickest people with antiretroviral therapy because that is what they needed, they wanted, they demanded. And many experts around the world said it's not possible, you can't do it, African people can't tell time, etc. You know the story. But it was the people themselves who demanded that treatment. But interestingly, it wasn't about treatment alone. And this is where the collaborative approach is so important. We, in our follow-up forms, once people had started antiretroviral therapy, and Louise will remember this well, as will Gregory, we had for the chief complaint at the first follow-up visit, as our drop-down questions, job, food, housing, school. And an expert came and said, these aren't chief complaints. And we said, you haven't listened to the community, because the chief complaints that people had were those material needs of their survival. And if we look at infectious diseases, emerging or not, as a disease rather than a biosocial phenomenon that impoverishes people, that puts people on the knife edge of survival, then we do not understand that. And we saw that in COVID, the very people who were unhoused, who didn't have the option of working from home, they were the ones who were affected in this country and around the world. So to think about a community-based approach, a community-centered approach, is to understand that the experience of everyone has to shape the response. And I have lots of examples of that, and we'll get back to Ebola later on. But asking people, what can I do with you together to fight this fight? And again, about terminology, when we think about decolonization, these terms are so passive. This is a fight that we have to make common cause and work together for justice. And so when we work with communities and say, what can I do? What do you need from me? And often the question is about materiality of suffering. I need food, I need a house. And it's very easy for experts to say, no, but I mean, in terms of the drugs. So we just paper over those material needs. And so because we're working in this legacy of violence, of violent colonialism, of violent oppression, racism, patriarchy, we have to position ourselves as a partner and a learner. And the people that I've learned the most about from addressing epidemics or health problems in general are the people who are suffering from those problems, who can tell me, if I open the question, these are the things I need. And medicines can be one carrot in that soup, but the soup is a much, much broader thing. And that's what we learn from community.
Thank you very much. You know, it seems, I'm going to sound naive here. It seems to me almost that it should be accepted, the norm, that you involve the community and that the people who you're trying to help should tell you what they need and how they are willing to accept your help. But I take it that's not so, or not always so. Gregory, I'm curious about your thoughts here. Can you talk to us a bit about some of the responses that you've worked on and when this didn't happen and how it affected the quality of the response?
Yes, thank you for this opportunity to really be part of this conversation. I think in this sense, what really come to my mind is I can refer to the cholera outbreak in Haiti, especially at the beginning. Back in 2010, when this outbreak started, and this was kind of new for the people who were affected by this condition, new for the providers also, because this was the first ever cholera outbreak in Haiti, and also new to the public health environment. So there was like a sense of panic and a sense of fear among everybody. And I think the failure that I can mention was around communication, lack of communication, miscommunication. So when I say lack of communication is, the nature of in Haiti, especially to kind of get the message out to the communities so that they understand the phenomenon that was really affecting them, and miscommunication as well in terms of how people really they perceive this condition at the beginning, to the point that in some region in the country, especially in the southern part of the country, so because the message, the right message didn't get to the people to really understand what was going on. We saw, and because of this fear also, people really started, in their own understanding, their own perspective on things, taking it to another dimension to say, oh, okay, this was due to the voodoo priest, who were cursing some of the communities. And that started really in the very wrong way that some of those voodoo priests were really lynching. And there were like 45 of them. So I think for me, this really resonated to the fact that in order to address the right response, we really need also to understand, the communities, to understand how people really, what's their perspective on things. And the right way to really do that, even before, starting with the standard public health approach, the biomedical approach on situation like this, is really to make sure that we get the people's opinion, get their, how do they understand the situation that they are living, and to go back to what Joa was saying, this collaborative approach, and also put things into context. So I can also mention briefly, like during the COVID pandemic in Haiti, we heard this, standard approach that messages around like COVID, stay home. But for some people, it's like, which home are we talking about? So some people didn't even have a place to stay. And or the place that, they had to stay, it was so, crowded. And, it was really impossible. The kind of public health messages that were around COVID that we could really, relatively easily apply here couldn't really be applied to Haiti. Say people stay home, or like you need to get food supply, but people are living like on a daily basis. So this kind of, contextual situation needs to really be understood and really incorporated into the public health intervention. So the social medicine aspect, the individual aspect need to be considered.
Great, thank you. Let's talk about this in the context of the US for a little bit. We've gone through a really punishing 3 years with COVID, and then last year, Mpox on top of it. Bisola, how well does the US do in fostering community-based responses? With COVID, it felt, sorry to use this term, but kind of top down, people were told not to go to beaches, tennis court nets were taken down. Things that were actually counterproductive occurred. Although last year, I would say with the Mpox outbreak, it felt much more like there was community engagement and much more work done with the community that was at highest risks. What are your thoughts?
So first of all, thank you for inviting me. I'm honored to be here. I would say that the short answer is that we're not good at it. You know, and I think that probably everyone in this room who's worked in the US would know that that probably is the best answer. But just taking a step back for a second, you know, the way that we've sort of been looking at this is community-centered responses during urgency, emergencies, community-informed responses, community-based responses. I think we need to take it one step further. Our responses need to be community-led, okay? And so that's really moving into a place where we're shifting power into community. I think another way to look at this is that when we have emergency responses, the way that we work is that it's often reactive that we bring community in. It's often delayed, and we do it in a functional sense. We need them for something. And so that is what I would call community outreach. It's unidirectional. It means that you go out, you give people a message, or you get them to enroll in something, or you get them to do something. Now, the more ideal response was discussed by Dr. Brand. You said community engagement. Okay, so that's partnership, that's sharing resources, that's sharing power, okay? But again, one step further, and what we should be learning from COVID-19, it's really community empowerment that shifts the dial. And it also means shifting power into communities. It means resources going directly into communities to get this work done. And that can be very uncomfortable, I think, as we start to talk about what universities do, what governments do, and how we look at resource allocation for the purpose of actually ending emergencies. So let me just give you an example, and then I'll talk about MPOX for a second. So if you think back to 2020 and you think back to the summer and then into the fall when there were the initial clinical trials. So if you think about that, you remember that there was a lot of concern about diversity in the clinical trials and generalizability of the findings. And what about mistrust if we don't have enough people of color? Because at the time, you know, mortality was 2 times higher in Black, Latinx, Indigenous populations than their white counterparts. And so at the time we did a lot of community outreach. There was money that was going, pharma was working with this one, that one around the country. But at the same time, there were communities that were saying, but wait a minute, we can do this, we can help enroll people, we can try to mobilize this. We know that Operation Warp Speed is occurring, but we can be the people who are actually doing the rollout of the vaccines. And so communities actually mobilize themselves in many ways. Here in Boston, we had the Black Boston COVID Coalition, we had La Colaborativa, which is already sort of working in the Latinx community. Equity Now and Beyond works in the immigrant community. So it was this type of work, people getting together, mobilizing, working amongst themselves to get it done that actually shifted things here in Boston. I'm telling you that from my own experience, okay? We actually closed the vaccination racial and ethnic disparities gap in April of 2022, and it's because we were funding these collaborations and these coalitions. That does not happen everywhere, and it's something that we should take as a lesson learned. Now, when we look at MPOX, so you said that it appeared different. Well, let me tell you just from the inside, I'll say that it wasn't so different, actually. And the reason why I say that is because initially, we as a public health community, I'm really talking about public health, we were afraid to talk about sex. We don't like talking about sex and sexual diversity. We don't like to talk about that. So we were avoiding those conversations. We were making a generalizable statement about how everybody could get MPOX, therefore we should all be concerned, we should all be wiping down our surfaces and washing our hands. Instead of telling people, hey, people who are sexually active, men who have sex with men, they are at highest risk, and we need to reach out to them and leaders within their community. By community, I define that as people who have shared beliefs, shared norms, shared language in some cases. Just reach into the diverse communities there and say, you lead this. You do the messaging. You get people to be vaccinated. You get people to come to the table and to discuss how we can end this. When that happened, I think we saw a shift. It happened more quickly, and that's maybe what we saw, is that you did see a rise in leadership. But I think that is the same example as community leadership. Community-led responses are really key.
That's great, and thank you for correcting me, because you're right on about that. Yeah, that your answer makes me want to talk a bit more about, you know, the U.S., but I do want to go further afield after that. There's, you know, an enormous problem right now with mistrust, distrust. I was talking about that in the last panel, and you know, one of the things I think about, having spent the last 3 years covering COVID, is that we learned a lot of stuff that is going to be really useful the next time this happens, and we may not be able to use a lot of it because people will be so resistant to masking. I mean, you know, if the fatality rate is higher, maybe that will change, but there is there's been such a polarization around public health. Public health departments have had powers stripped from them across the nation. This, I mean, I find this quite frightening, to be honest. If there was more of the type of engagement that you're talking about, could we break down that distrust, mistrust within communities? And I'd like all of your thoughts on that, please.
Yeah, I want to jump in because I also want to add to what Basolo is saying. I think part of the problem is we're talking about during outbreaks. What about the other times? And I think what I've seen around the world, including in the US, is why now? Why do you care about me now? You know, my sister had a broken leg, couldn't get fixed. I've been on a waiting list, you know, forever for, you know, to get a mammogram. So you can't suddenly run in because it's convenient for you. And I think that's part of the brutality of this emerging infectious disease, global health security architecture. It's clear to people in community that you don't really care about me, you care about you. Right? You're trying to protect it from coming to your doorstep. And we saw this a lot in Ebola in West Africa, where people didn't trust the health system because the health system sucked. It wasn't like, oh, it's Ebola. They don't want to go in there because every hospital was a death trap before Ebola. Right? And so it's hard to get people to engage suddenly because it's worrisome to us in the West. And so that's why we have to focus on community participatory approaches now, all the time. Improve health through a horizontal collaborative approach so that when these things happen, and we were talking a bit at lunch about Rwanda. Rwanda had a beautiful response to COVID. And within a month, they had 134 cases from their first few cases, whereas Georgia had 8,000. Right? And they're the same size. And what was that about? It was about the people are used to the government actually doing healthcare, doing it well. And you can say what you want about the governance or whatever, but people understand that the health system is actually there to provide services for them. And I think we have to build that in the in-between times if we think we're going to be able to respond to a pandemic.
Yeah, I can probably elaborate a little bit on that, sharing a little bit of my experience for having worked in Sierra Leone, after the Ebola and how really people reacted during the COVID-19 pandemic. And I think it's related to the vaccine campaign. Even myself, and I was really impressed by the way that people really kind of, even if the system itself is not really optimal and really a broken health system, but in terms of trust in the public health authorities there. When we even they launched the vaccine campaign for COVID, so I myself was kind of skeptical that people would not really be willing to take the vaccine, especially that COVID was not really, didn't really hit hard really too much there. But over time, I saw that how people were really lining up to get the vaccine because there was this trust also in the public health context. So I think it's really important that, and also because I think there is a huge emphasis in communities like this in the involvement of the leaders of the community, and also making sure that from the villages, to the chiefdom, as they call them, people are really involved in passing the messages to the community so that they can really understand how it's important for them for things like this to take the vaccine and really really collaborate.
So if I could chime in just rather briefly. So prior to taking on this role as Commissioner of Public Health for the City of Boston, my academic work was actually focused on understanding mistrust and conspiracy theories, but it was really related to HIV. Then we shifted into COVID-19. So this is an issue that people oftentimes ask me, so what should we do about mistrust? Similarly to this, like what are we gonna do now that people don't trust? This is not a new phenomenon. This has nothing, it's been amplified, highlighted it's been written about. We all know that it's there. You know, our systems have never proven themselves to be trustworthy, therefore people don't trust them. I mean, this is obvious, and so many people will talk about Tuskegee in the Black community. This is not about an episode. This is not about an event. This is about the chronicity of dysfunction, the chronicity of structural violence, what's been going on for centuries. So it's nothing new, and it's been going on for a long time. So the question is, what do you do about it? Well, a lot of times people will say, well, let's be more transparent. Let's, as I said, be more engaged with community partners. Let's develop real, collaborative structures, and I think that's great. But what we need to do is sincerely invest in the inequities that have caused the problem. I mean, that has to be a real investment. It has to be earnest. Yes, it has to be sustained. It has to be what we say we are going to do. Everybody thought, and I'm sure we all heard this, COVID was going to be an inflection point. We were going to change. There was going to be real structural change, a true shift in how systems work. Has that happened? No. So then how sincere were we in the first place? And that's what I'm saying. If you really want if you really want people to trust, we have to be sincere and do things differently. So.
Well, I was going to ask, about how if you built your responses around community-centered actions and found out what people wanted, whether it would help to build infrastructure and help to build expertise in other settings, particularly I'm thinking here. But it sounds like from what you're saying that we have to do it before, not after. And how do you get... continuously. But how do you get people to take that seriously and invest in that? Because you can see what's happening now. Everybody's acting like we just went through a 100-year storm, and now we have another 100 years in which we can just ignore infectious diseases and go on about our business. I mean, they don't want to spend any more money on COVID here, and God knows on whatever else. So I just wonder how if this event did not inspire people to take infectious diseases seriously and plan for and work towards maintaining preparedness, what is it going to take? Anybody got an answer?
Yeah, I'm happy to answer, but I'll let one of you guys go first.
Because I just came from the budget breakfast, so I've been talking with city councilors all morning about this issue. Let me just weigh in and say that I think it's about having the right leaders in place, and I think we underestimate who we put in places of power, and we need to take that very, very seriously. I think it's also just about being persistent, and I say that I'm trying to be hopeful, you know what I mean? I'm trying to say that I've talked to commissioners, and let's just talk, domestically for a minute. I've talked to my colleagues across the country. There are commissioners of public health. There are people who are working in departments of public health, and they believe that this is what we should do. But at the same time, we are getting money taken from our COVID lines and pulled into other emergencies, other crises. So it's up to me to fight the good fight. I mean, literally, it means talking to people and trying to develop the right strategies to get them to let us keep 5 million here, because we know we need to prepare communities. And one of the things that we're doing here in Boston, I'm trying to advocate for, is having a community health empowerment fund. So actually having money that's there, that's ready to fund these different coalitions, so that they can not only work on continued efforts under COVID, but also all the other disparities that we're talking about. I mean, we could run the gamut of all the disparities and all the issues that we have to deal with. So I'd have to say it really is about that. And then in addition, I would also add that it's really about communities standing up for themselves. Okay. So I'll just say this and then pass it on. I don't know how many of you know about the Black AIDS Institute. So it's an organization that started in 1999 by Phil Wilson, a Black gay man, who basically came together. It came together based on a lot of these issues of mistrust. So in other words, they said we can do this for ourselves, and the actual model is our power, our people, our problem, our solution. Okay, so it is about communities saying, you know what, we have resilience, we can do this ourselves, and coming to the table, which they do. If you say, here, open the door, and you say, here, come to the table, let's talk about it, and doing some advocacy on their own.
Jaya, did you want to add something?
I mean, I think just to probably elaborate also this, I think this approach of having, like after really experiencing situation like this, we need to have a sort of way of creating a space, creating platform where the conversation can continue. So one thing that, for instance, I really appreciate like seeing in Sierra Leone is like the Sierra Leone Association of Ebola Survivors, and they are really actively involved also in, and trying to influence and, do advocacy work. And they need obviously to be more empowered over time. But I think, Bill, on what, you just said, it's really to make sure that we create platform where we remind ourselves that really that really has happened. We didn't handle it well, and we need to get ready for the next, for the next emergency response that we need to for other outbreaks like this.
Yeah, I would just add on that, like, I think the platform that Gregory is talking about has to be this collaborative platform. I think it is about leadership, as Bisola is saying, but I would say it's much more about civil society. We have to make spaces for affected people to be decision makers. And good leaders will do that, of course, so leadership is important. But if we don't create the space, I mean, what to me defines more than anything else the success in the AIDS movement is people living with AIDS at the table every day. You cannot have a meeting without, you cannot have leadership without that. When we hear about the great work in Colombia, this is civil society taking power. And I think criminalizing dissent, as we saw this week in Tennessee, is one of the most dangerous things that can happen toward any kind of equitable response to whether it's a pandemic or the massive disparities we see, without any infectious disease in the US.
Okay, I think we have time for one question. Is there somebody in the audience? Maybe if it's the question is short, the answer is quick, we will get to. Wait, you're going to get a mic.
Sorry. All right. I just want to say how rich this conversation has been all day, as many people have said. But one of the things that I haven't heard you talk about, and I served as health commissioner in New York City and in New York State, is what's happened to government, and in particular to public health, and the extreme privatization of government activities. It was on full display during COVID. Private companies providing the tests, private companies providing the vaccine, and the loss of, government invested a lot in the vaccine, but it's private manufacturers soon we're going to be paying private prices for these. And I just would like, I would like you to say something about that, because the notion that communities can just pull power from numbers is one that doesn't take into account the real realignment that we've seen in, say, the last 50 years that has so undercut the effectiveness of government public health.
Okay, no, okay. Yeah, I mean, Mary, amen to that. And, I think when we think about the dialectic that's needed to assure human rights, it really has to have both a community part and a government part, because private corporations have absolutely no interest or responsibility in delivering in human rights. And so because governments and the public sector has so abdicated, particularly in this country, abdicated any sort of public contract, I think it becomes very impossible for communities to really, now we're trying, but I think the public sort of rebuilding a public contract, and we've tried to do this at Partners in Health. We worked very closely to help draft the Public Health Jobs Corps Act. We got that money to go to Immokalee, Florida, one of the most heavily hit communities, majority migrants from Mexico, Guatemala, and Haiti. And when that money got there, to hire Haitian community health workers to work for, and Mexican and Guatemalan, to work for the federally qualified, the closest thing we have to public clinics, the county, Collier County, turned that money back to the feds. And there were protests outside of the thing saying, oh, this is violating our health freedom. We need to figure out who's paying for those protests, because that is a corporatization that we don't want this public contract. So we have to follow the money, and we have to really make that plain.
No, I totally agree with that. But let me go back to this issue of privatization and what we saw during COVID-19. I think we all saw this incredible, enormous shift to private industry in controlling what was happening, and not just supplying, but actually making the decisions. And that was very concerning, but it was also, the reason for that was because public health infrastructure has been so devalued, so underappreciated for decades, and underfunded. That's where I was going. That was my next under, right? And underfunded for decades. And no, but it's not only that it's underfunded, but it's the way that it's been funded. It's been funded to focus in on disease entities as opposed to the infrastructure, our people, our lab sources, our laboratory services, our data, everything that makes a public health system what it should be in this country. If that was not the case, private industry would not have an opening. And I think that is what we need to learn from this. And where I say government comes in is that I do think there has been an understanding of this. Now, whether or not people are really truly acting on it, I don't know. The CDC is putting a large sum of money into jurisdictions to focus in on building public health infrastructure. This is a once in a lifetime. It has not happened before here in the United States. If it happens again, that's great. It's not a lot of, here in Boston, we got 8.9 million. That's not a lot of money, but it's something. I think what I was concerned about was that with the American Rescue Plan Act, which is the $1.9 trillion that the United States gave out and spread around the country, at no time was there a plan to mandate community involvement in exactly where that money went, okay? Now, health departments may have chosen to do that, but at the top, that was never the plan. It went to cities, it went to counties, it went to different jurisdictions. And I think that is where a lot of things need to change, because it is communities who can make those decisions about transformative investments in actually what will happen the next time we have a pandemic.
Would you guys mind if we take another question instead of doing the closing comments? No. I think the gentleman there wanted, can somebody get him a mic, please? Yes.
Sorry. Thank you. I'll sit so I don't block the view for the folks behind. I'm an ER physician, and that's the context of my question. Yesterday on television, the gentleman who was the chief medical officer of the hospital that handled all the shootings made a statement that said, I'm a doctor, so I don't know what the right solution is. And he was obviously calling for gun control, but those were the words he used. And I think physicians have been taught to be skittish around taking political positions. So thinking about, and this has not always been the case, PSR and PHR have literally changed the world through the Landmine Ban Treaty and their role in nuclear disarmament, right? I'm thinking about Joya's chief complaint list. How do we get the American medical professional societies, all of them, who won't even come out in support of universal health coverage, to come out in support of universal basic income?
I mean, I guess it's not my, in some ways, it's.
I didn't mean to put you on a spot.
No,
but
it's fine. I don't mind.
Like that's where we
I don't
should
mind
be.
because I have no skittishness about politics, because, I mean, I believe what Virchow said about medicine being inherently political. And I think that I'm not as concerned about making a medical professional group do this or that. But I will listen to people and try to have people hold us accountable. And, FDR famously said, I know what to do when he was drafting the New Deal, but he said, you guys have to make me do it. He probably didn't say you guys. So I think it's really about making common cause with people who are fighting and building public institutions, because without public institutions, we don't have a shot. Because there is no incentive, unfortunately. I mean, when I started doing AIDS work many years ago, I had a discussion with a sort of progressive economist, if there are such things. And I said, well, can't we show that there's some merit to saving this person's life who's a peasant farmer in Haiti? He said, there's no way, because that person doesn't contribute to the economy. And the only measure we have is the contribution to the economy. So until we value value people's lives for the existential meaning of them, we have to really listen to voices and have a public approach. Otherwise, there are many of our colleagues in the medical profession who are part of a capitalist structure, as we all are, really. And so I'm not as worried about changing our profession.
No, please.
No, I just wanted to, I think we kind of commented also on one aspect of this, which is like, making sure that we got the right people in terms of leadership, at the right position. And I think for me, it's also create this movement. What we are doing now, I think it's not superficial, it's really deep and profound. And I think it's like preaching the gospel so that people continue to hear this kind of different approach and take advantage of momentum. And just like we said, COVID-19 has really created a momentum really to show disparities and to show some other approach in emerging infectious diseases like this. But I think we have not really taken as much as we could for this momentum that has created, and we need to make sure that we don't really lose this momentum and continue to create this movement around all this word that we are using now, decolonization, and also like making sure that we kind of in terms of disparities and give voice to the people who are really suffering most from those conditions and who don't really have access to the basics. So I think that's something we need to continue to do.
Last word, Judy.
Oh my goodness, okay. So actually, I was going to go back to the question that was asked about medical societies, because I agree with you, Joya. I don't pay so much attention to our professional medical societies, honestly. I'm not a member of the AMA. However, I was recently looking at the amount that they spend on lobbying. And if you combine the amount that the American Medical Association and the American Hospital Association spend on lobbying alone, I think it was in 2020, it was like $47 million. Compare that to what the American Public Health Association spends on lobbying. Somebody guess. $97,000. That was in 2019. I think it went up to 115 in 2020. I think what's missing here is we don't value this work. We don't value human lives, and we also just don't value the public good, public health, the way that we collectively should be focused in on the health and well-being within communities, amongst populations. Something is just not right here. It's going to cause really a shift philosophically in how we look at the work that all of us are doing. So I'll leave it there and just say that some change has to occur. The structural change that changes our systems and how much we truly value public health needs to change.
Wow. Interesting.
Well, thank you, Alan, Helen, Joya, Basola, Gregory, for those really phenomenal comments and discussions. If you joined a little later today, I want to reintroduce myself. My name is Louise Ivers. I'm the faculty director for the Harvard Global Health Institute, and I just want to make a few closing comments and then welcome everyone who's here with us in Cambridge to join us for a reception to talk more and to chat and process everything we've heard today. But I'll start with a few thank yous, because I'm coming to the podium really filled with gratitude. You can plan a symposium, you can think about bringing people together across disciplines, you can try to have it be in person and hybrid, and then you can see it manifest. And I have to thank all of you participating here in person. It's phenomenal to be closing out the day with a full house here in person and a full virtual audience. It's really been just fantastic. So thank you so much for being here and joining us. I want to thank the Faculty Club staff for hosting us and having such a lovely day. I want to thank the AV team for helping make such a lovely hybrid event that went so seamlessly. And I want to thank the HGHI team who've worked tirelessly for the last few months to put this together. And then I really just want to thank so much the participants, the speakers, the moderators. You know, you all were really chosen through a very deliberate process that we thought about what we wanted to talk about today. Nothing was by chance. There weren't any accidental conversations. We really wanted to have this rich conversation, and wow, you really brought it. Everybody thought very deeply about the topic. Everybody engaged in the topic in a really meaningful and profound way. And I personally just had so many profound moments during the day, and I'm not going to try to summarize them. I think that would be just too hard to do. But I did feel that through all the discussions, there's this really thoughtful sense that to advance health equity, to advance global health equity or local health equity, to achieve health for all, we can't disconnect the different pieces of it. This work is very interconnected. You know, we have to think about planetary health, justice, human rights, decoloniality, community-led work as frameworks to advance health. And if we're not thinking about those frameworks and how they work together with a holistic approach, we're probably not going to make the kind of progress that we're all thinking about. And we have to think about those things: justice, decoloniality, planetary health, human rights, not in a performative way, but we really have to think about them as actual mechanisms for us to have impact. And everyone today spoke about action and action for impact. And so I think that action-oriented and respectful partnerships are really an important lesson from the conversations we've had today, grounded in the notion that we must learn from history and we must learn from each other. And we have to radically change business as usual and make it business unusual, which is what Dr. Ogwell called on us to do. I think it's important to not shy away from the conversations we've had today. And I'm hopeful that the Harvard Global Health Institute, as we move forward in the months and years to come, can be an important part of a brave and courageous set of actions to step forward into achieving health for all. And I'm so glad that everyone was here today, and thank you very much. Please join us in the reception area.